Good evening, everyone. I, Dr. Sunil Pandey, welcome you for the second and the final session on our accredited virtual conference, which is on current insulin therapy. For the benefit from the organizer perspective, this is organized by Help Defeat Diabetes Trust, along with Dr. Chandalia's Diabetes Endocrine Nutrition Management and Research Center, also in collaboration with the Association of Diabetic Educator and Jaslok Hospital and Research Center. Next slide, please. This virtual conference on current insulin therapy has been conceptualized and developed by Dr. Chandalia's Diabetes Endocrine Nutrition Management and Research Center, that's Denmark, as well as Help Defeat Diabetes Trust. May I welcome our course director of this virtual conference, Professor Dr. H.B. Chandalia. Few words about our course director. He's the Director, Endocrinologist, Diabetes and Metabolism, Jaslok Hospital, Mumbai, as well as being the Director of Diabetes Education, Nutrition Management and Research Center, Denmark. He has been the editor of International Journal of Diabetes in Developing Countries. He has been the Honorary Professor of Medicine Diabetes, that is Grant Medical College. Also, the Editor-in-Chief, RSSDI Textbook of Diabetes, 3rd edition, 2015. May I call upon and request our course director to please provide the context of today's final episode of Accredited Virtual Conference.
Thank you, Dr. Pandey. Dear colleagues, a few words about the context setting of the CME, the second session of current insulin therapy. The purpose of this CME is to familiarize our colleagues on how to choose a proper insulin for their patient, when to give insulin, and which insulin to choose, what tool is the best for you, and how to use that tool. Most of the doctors get inhibited while initiating insulin therapy because of fear of hypoglycemia, which they have as well as the patients have, and how to get around these problems and institute insulin therapy without undue incidence of hypoglycemia is truly the science and art of insulin therapy. So we're going to make you confident in using insulin once you have gone through this CME or last Saturday's and today's CME. Those of you who are looking for the credit hours for MMC, kindly do fill in your full attendance because MMC makes it mandatory, and of course return your response forms at the end of the session or soon thereafter. I think with these words, we'll start with our first talk of today. And the first talk is on insulin therapy in hospitalized and critically ill patients. The speaker is Dr. Shaimal Chandalia, and chairperson panelists are Dr. Debashish Basu and Dr. Dhruv Singh. The time allotted to these two or three people has been shown on the screen. To introduce our chairpersons, Dr. Debashish Basu, he heads an organization called Diabetes Awareness and You, which is doing human service in educating people with diabetes all over the country. He works out from Calcutta. He's the senior consultant, Apollo Green Acres Hospital. And of course, he was involved in setting up the sugar clinics or Apollo, co-director of many courses where diabetes is being taught. And he is the Indian faculty on FID Medaversity under the aegis of Royal Liverpool University. Dr. Dhruv Singh is a consultant diabetologist at the Chess Diabetes Center at Andheri, Mumbai. He has been associated with Hertfordshire University. He did his MD from there in diabetology, and of course worked for I think about 4 years or 5 years. And you see, he continues to be honorary senior lecturer at the same university. And of course, he has received his special training was in diabetes and mainly renal medicine. And of course, he received a doctorate from that university and postgraduate diploma in diabetes from Bradfordshire University. So Dr. Shaival Chandalia is consultant endocrinologist and diabetologist at Jaslook Hospital Research Center for the last more than 12 years. He works with us at our center as endocrinologist and diabetologist. He has authored or he has assisted us in a very interesting book we are reading, which is doing very well for the last several decades, and of course contributed a few chapters in the RSDI textbook of diabetes, the third edition. So with these words, I request Dr. Shaival Chandalia to deliver his talk.
Thank you, sir. I'll just go ahead and start sharing my screen. Just give me a minute. I hope my screen is visible now.
Perfectly fine. Please go ahead.
Okay. So my topic for today is management of diabetes in hospitalized and critically ill patients, which is a very important part of the treatment of type 2 diabetics. So it's not only outpatient, but also inpatient diabetes that we are asked to deal with and handle. So there are various barriers to inpatient diabetes management and the way it differs from outpatient diabetes management. There are increased insulin requirements due to illness, exaggerated variability in subcutaneous insulin absorption. There is, of course, the NPO, nil by mouth status, inconsistent oral intake, interruption of meals by procedures, unpredictable arrival of meals, and inability of patients sometimes to participate in management decisions. And all these present challenges to us that we have to overcome. Medication errors also may play a role. Management of diabetes in hospitalized patients, I will divide my talk into 4 sections. First, we will talk about significance of metabolic control in the critically ill, that is in the ICU setting, and of course in hospitalized patients. Then why do we prefer insulin over other oral hypoglycemic agents or anti-hyperglycemic agents? Which insulin, what the different types of insulin that we use, and how do we use the different types of insulin that are available to us. The significance of metabolic control in the critical illness. Now, there has been a lot of evidence in the past that hyperglycemia has an effect on our white blood cells, specifically granulocytes, by various biochemical pathways, resulting in dysfunction in phagocytosis, adherence, chemotaxis, and this has been known since 1978. So this was the beginning of evidence about the role that blood glucose plays in our defense against infection. We also know that blood glucose has an effect on the cardiovascular system. It can impair ischemic preconditioning. It can cause some damage to neurons, astrocytes. It increases the risk of thrombosis, inflammation, and endothelial dysfunction. So this is the reason why in the following conditions or situations, glycemic control, even short-term glycemic control in the hospital becomes important. So whether it's in critical illness, acute myocardial infarction, post-operative infection or wound healing, in-hospital mortality or stroke, because hyperglycemia has an impact on all mechanistically on all the different organs and the immune system, which I talked to you about. These are the situations where short-term glycemic control and will be important in the hospital. And this covers a large fraction of our hospitalized diabetic patients. So we know, as I mentioned, since 1978 that phagocyte dysfunction, granulocyte adherence improves with better control. And it was found that cutoff of a level of about blood glucose of 200 was seen, above which the dysfunction was significant. So a ballpark figure was available to us even way back in 1978 or 80 that you need a blood sugar below 200 in order for your phagocytes to function appropriately. Also, when your blood sugar is more than 200, it spills in the urine, and this glycosuria can be responsible for caloric loss, for dehydration, osmotic diuresis, and so it can be detrimental. Again, in 99, there was a study which showed that if in cardiac surgery patients, if the blood glucose is less than 150, it gives the lowest mortality. And then we come to one of the landmark uh, trials by Vandenberg, uh, which is also called the Leuven trial because it was done in Leuven in Belgium. This was published in the New England Journal of Medicine 2001. And it was based in a surgical ICU unit in the Leuven hospital, where uh, intensive control was compared with conventional control in these surgical ICU patients. And a mean blood glucose of 103 was achieved in the intensive arm versus 153 in the conventional arm. And it was found that with lower blood glucose, there was a 45% reduction in ICU mortality. This is surgical ICU mortality in both diabetic and non-diabetic patients. So this was one of the first indicators that controlling blood sugar in a surgical ICU has an impact on mortality. However, remember that there were some deficiencies with this study. For example, it was a single center study, so there is some bias introduced in a single center study. Secondly, a large amount of glucose was given in the first 2 to 3 days as a nutritional supplement, and the thought was that the high mortality in the conventional arm could be due to a deleterious effect in that arm, and that's why there was a reduction or improvement in the intensive arm. And actually, the deleterious effect was the reason why this trial became a positive trial. Now, this was followed in 2003 by an observational study where 1826 consecutive ICU patients were observed, and it was found that as their average ICU glucose increased, the mortality increased. So this was an observational study which added more information to our previous landmark Leuven trial. Again, this is data from the Leuven trial, where you can see the cumulative percentage of mortality or in-hospital death was much higher when a blood glucose was more than 150 versus a blood glucose between 110 to 150, and it was the lowest when the blood glucose was less than 110. And hence, this forced the American Association of Clinical Endocrinologists to make a target of in the ICU of a blood sugar of about 110, and in non-critical care preprandial of 110, and a maximum of 180. However, the Leuven trial was followed by a couple of other trials which made the results of the Leuven trial debatable. For one, there was a second Leuven trial, where Vandenberg took medical ICU patients. In the first, it was surgical ICU. Now, and in the second, in 2006, it was medical ICU patients. Again, it was a good number, around 1,200 patients, and it was found that even in the medical ICU patients, there was not a reduction in mortality in the intensive versus the conventional arm. Finally, this trial kind of put everything to rest, put all the debate to rest. It was called the Nice Sugar Study, which was published in NEJM in 2009. Again, there was a good number of patients, 6,100, out of which half were in intensive control, the other in conventional control. The intensive group target was 81 to 108. The blood sugar was very tightly controlled. Conventional group target was blood glucose of less than 180. And it was found that in the intensive group, in-hospital death outcome at day 90 in hospital, and as well as death later on, there was a higher incidence of death in the intensive arm of 27.5% versus 24.9% in the conventional group. And this odds ratio was 1.14 with a significant p-value. Incidentally, hypoglycemia was also much more in the intensive arm. So it could be that hypoglycemia is one of the methods by which intensive control in a mixed surgical and medical ICU multi-centric trial like the Nice Sugar Study. It was done in New Zealand, Australia, and Canada. In this multi-centric trial, it's possible that hypoglycemia precipitated increased death at the end of 90 days in a mixed medical and surgical ICU setting. So therefore our targets needed to be revised, and now we say that our targets in the ICU, medical or surgical, should be less than 180 or a blood glucose of between 140 to 180. And you can extrapolate that to other hospitalized patients. So remember two trials, the Leuven trial for the first trial, and then of course the nice sugar trial, which put a lot of this to rest. Now, why do we use insulin? What is the evidence versus using OHAs and that is oral hypoglycemic agents and oral anti-hyperglycemic agents? The classic indications of insulin therapy, of course, in the OPD or in the inpatient setting, type 1, type 2 failing OHAs, acute metabolic emergencies, diabetics with hepatorenal problems, or with severe vascular complications and neuropathy, or in the pregnancy setting. But it is important to remember that insulin therapy also is used in situations, or is more favorably used in situations which demand flexibility of treatment and need for combating a catabolic state, which is seen, these two conditions are seen in the hospital. So insulin offers flexibility of treatment. You can give 3 shots a day, 4 shots a day, and bring down the blood glucose quite dramatically, quite quickly, and control much faster than you do with oral hypoglycemic agents. And also it has an anabolic effect, which is also very useful in the hospital. In comparison, oral hypoglycemic agents or anti-hyperglycemic agents, the onset and offset of action is slow. Hence, it does not offer flexibility. Some of them are contraindicated in hepatic renal disease as well as in anorexia. In particular, if you look at sulfonylureas, they can cause hypoglycemia. They are inflexible. If you stop the dose today, the effect will still be there for a couple of days. They can reduce ischemic preconditioning, predispose to arrhythmias, metformin, lactic acidosis, especially with congestive heart failure, chronic pulmonary disease, chronic renal failure, which is very commonly seen in the hospital. These are contraindications. Thiazolidinediones, if you start them today, the effect will come after 15 days. They also cause volume expansion and contraindicated in CHF. Acarbose, the metabolites are increased in hepatic disease. SGLT2 inhibitors can cause caloric loss as well as hypovolemia and UTI. However, insulin resistance often requires combination therapy in type 2 diabetics. Therefore, you can use short-acting secretagogues like ripaglinide or DPP4 inhibitors, or carbohydrate blockers like voglibose in association with insulin in order to achieve a more smoother control in your hospitalized patients. Now, if you come to which insulin and the types of insulin available, of course, in the pre-analog era, there was we preoperatively used to use a 3-dose regimen of plain plus NPH, and of course in the surgery and immediate perioperatively used to use plain insulin, whether intravenously or otherwise, and then postoperatively again a 3-dose regimen. Of course, now you have availability of glargine 300 and 300 and digludac and Lispro and aspart, as well as glulicine, which can be used even after a meal in hepatorenal disease and variable food intake. So these offer certain advantages in reducing the risk of hypoglycemia and giving flexibility with regard to variable food intake and hepatorenal disease. More or less, I would say you would like most patients, these are the various insulin regimes used in the OPD. You would like that in the hospital, the patient be on a basal bolus regime. So 1 long-acting insulin as well as 3 short-acting insulins with each meal. And it is found that this mimics the natural pancreas. So in a normal person, there is some insulin secretion in the fasting state, and then there is a bump in insulin secretion in the prandial state to take care of your blood glucose, which increases in the prandial state. And this is affected, of course, in diabetes. But if you have a basal bolus regimen, 3 shots short acting as well as 1 shot long acting, then you can mimic this situation. And out of the 3 meals, the largest dose is usually at breakfast time because of the counter-regulatory hormone surge in the morning. So remember that although breakfast is one of the smallest meals, the insulin requirement at breakfast is probably the largest. And of course, you have some increased basal requirement at night. Insulin therapy in perioperative period. Now remember, if it's a planned surgery, then you may want to start insulin at least 2 weeks preoperatively. Of course, it's an emergency surgery, then a 2 to 4 hour infusion to correct electrolytes and combat ketoacidosis may be used. That is insulin IV used in order to achieve as good a homeostasis as possible. Now, in the hospital, I talked to you about using basal bolus. So remember, you are using basal insulin as for background glucose taking utilization. Then you use prandial insulin in order to control your meal-related surge in sugar. And you use a correction insulin, which is usually the same type as the prandial insulin. This is called supplemental insulin, to treat an acute elevation in blood glucose, which you see pre-prandially. So if your pre-meal sugar is high, then not only is basal insulin around, but you're giving prandial insulin at that time. You get a sub-correction dose in order to control your blood sugar at the time of the meal. So components of the insulin regime are basal, prandial, and correctional. And the correction is given at the same time as the prandial insulin before a meal. So remember, in a healthy person, the percentage or the relative proportion of insulin, correctional insulin that you use is smaller, while it is much larger when the patient is sick or nil by mouth. So remember, 3 components: basal insulin in the background, prandial, and correction at the time of a meal. So the correction dose is additional insulin for pre-meal hyperglycemia. It can also be used in between a meal, and it can be given as regular Lispro or Aspart. Sliding scale has fallen out of favor because insulin is omitted when the blood glucose is low, followed by hyperglycemia. Then a large dose is given when the blood glucose is high, followed by hypoglycemia. So the patient slides between hyper and hypoglycemia, and it is a post facto action. So it is better to give a fixed dose before each meal and correct that fixed dose upwards or downwards. That is the correctional dose in order to control your blood sugar. You can link it with the patient's pre-op requirements. About 20 units per day can be the starting dose if patient has not been on insulin. You can decrease by 50% if there's hepatic or renal disease or diarrhea. And you can double the dose with insulin resistance, obesity, concomitant steroid therapy. You remember, steroid therapy has a lot of postprandial hyperglycemia, but not a lot of fasting hyperglycemia or TPN or post-renal transplant. So you double the dose in those situations. Anesthetic agents like general anesthetic agents can increase stress. There is also the nil by mouth situation, physical inactivity, therefore insulin demand can increase. You can tackle this by reassurance, using spinal or local anesthesia when possible. IV dextrose can be given. You can ambulate the patient soon after surgery and increase insulin doses. Now, how to use insulin? There are various delivery methods. Subcutaneous insulin, of course, which I talked to you about, basal, prandial, and correctional doses. It has a high coefficient of variation, 30 to 40%, because the absorption is affected, of course, by the concentration, the dose, the site of injection, depth of injection and technique, exercise, massage, etc. So in that situation, falls short of what intravenous insulin can provide. But do remember that even in a type 1 patient, although you may give intravenous insulin, subcutaneous insulin should also be provided or given twice a day, because subcutaneous insulin results in a depot forming in the subcutaneous tissue. And intravenous insulin, as I will show you, has a half-life of about only 5 minutes. So there is no depot. So once you stop the intravenous insulin, immediately there is lack of insulin in the body, and in a type 1 patient that may be dangerous. So therefore you can continue subcutaneous. This is where subcutaneous insulin scores over intravenous insulin. There's a depot, and that from that depot gradually the insulin is absorbed. So I was talking to you about intravenous insulin. A single injection will result, it has a half-life about 5 minutes, and it is out of your system in 20 to 30 minutes. That is called an insulin bolus. If you give a continuous infusion, then of course it takes a time for the insulin levels to build up, and then finally they build up. And if you give a bolus plus a continuous infusion, then not only you get a good insulin level initially, it is followed by a good insulin level soon after that. Do remember there are factors affecting insulin absorption. So when you prepare an insulin infusion through a syringe pump, if it has glass or PVC, then there could be 30 to 40% adsorption to the or adherence to the sites on the inside of that polyvinyl chloride, which result in less insulin being delivered to the patient. And therefore, we say you flush the first 10 ml through that syringe pump and tubing outside the patient, and after that, you connect it to the patient and start delivering insulin through the infusion. Now, there are various protocols. This is the Leuven protocol or the Vandenberg protocol, which I talked to you about. Then there was a Markowitz protocol, a computerized system called the Gluco Commander. So in the Markowitz protocol, you got 4 algorithms. And if your blood sugar did not drop by more than 60 within 1 hour, then you move from algorithm 1 to algorithm 2, where for the same sugar, you have a higher rate of infusion. So then if the blood sugar doesn't drop by 60 in 1 hour, then you move to algorithm 3 and so on. So it became a little complicated. Now, the ideal IV insulin protocol would be one that is easily ordered, effective, safe, easily implemented, and able to be used hospital-wide. And so we have now framed for the last almost 30 to 40 years an insulin protocol in our current setting, which is in Jaslok Hospital, where we use, for example, we prepare a syringe pump and we use 50 cc of saline with 50 units of human regular insulin to prepare the insulin infusion in that pump. Then, depending on the blood glucose, a certain rate of that infusion is specified, and we check every 2 hourly in order to change or adjust that rate. Now, the advantage of using this and changing the concentration rather than the rate or the scale is that you don't have to go through those 4 algorithms which I just showed you when the sugar remains high. So if the sugar remains high using this 50 by 50 infusion, then instead of changing the scale, you can change the concentration, like make it 75 in 50 ml or 100 units of regular insulin in 50 ml of saline. And the nurse has to deal with the same scale as long as, even when the concentration of insulin, whether it is 75 by 50 or 100 by 50 is changed. So nurses have a very simple way of treating our patients in the critical ICU or in the hospital, where they use intravenous insulin and a fixed scale. Only we change the concentration.
Dr. Sheval, 2 minutes left.
Yeah, I'm just about finishing. Now, there are 2 other things that we do. We reduce the infusion rate to half the scale from midnight to 4 a.m. because that is the period of maximum insulin sensitivity. And secondly, if the baseline blood glucose is very high and there's a significant drop in blood glucose, or if the potassium is borderline or low, it is mandatory to check the potassium levels because it can drop with the insulin infusion. So in a surgery grade, you can use dextrose plus insulin preoperatively. Intraoperatively, we usually reduce the scale of insulin, or if you're adding insulin to the dextrose, then you can change to a plain dextrose, because hypoglycemia under anesthesia can be catastrophic and devastating. It can cause anoxic or what we call as hypoglycemic severe encephalopathy, and that would be catastrophic. You cannot recognize it easily under anesthesia. So we like to keep the blood sugar a little high during anesthesia. And post-operatively, again, you can go to dextrose plus insulin. So you can use the intravenous insulin in 2 ways. Either you add it to the dextrose and run the pint, or you separate it by using a separate infusion pump or a syringe pump and give it separately from dextrose. And of course, IV to subcutaneous insulin, there is an overlap required, because remember, subcutaneous insulin takes a couple of hours for its level to come up, and intravenous insulin, if you stop abruptly, then in half an hour or in 5 minutes, 5 to 10 minutes, there is no insulin in the system. Also on discharge, my last 2-3 slides, you can optimize insulin therapy with a sensitizing agent and use metformin, DPP-4, SGLT2, or a sulfonylurea. This, of course, is in renal failure. Remember, you give small doses of short-acting insulin. On the day of hemodialysis, you lower your insulin dose. Peritoneal dialysis, of course, variable dosages depending upon the glucose concentration in the dialyzing fluid. And post-transplant, you use an infusion pump and give multiple daily doses. In hepatic disease, tendency towards fasting hypoglycemia is there, so avoid long-acting insulin, avoid all OHAs. Most preferable is short-acting insulin like aspart and lispro. So meticulous metabolic control of diabetes in hospitalized patients is extremely important. Outcome measures have shown clearly the benefit of this approach. Targets should be individualized in every patient and every effort made to achieve the same without distressing hypoglycemia. Most hospitalized patients need to be on insulin infusion or rapid short-acting insulins. There is a limited role of short-acting reno-hepatosafe OHAs as sensitizers or adjuncts. Discharge advice depends upon the response during hospitalization and the long-term requirement dictated by the basic diagnosis. Thank you everyone for your patient hearing.
Thank you. Thank you, Dr. Shawal. Now I would invite the chairpersons and panelists to kindly initiate the discussion. And very soon, if the questions come in the chat box, I will direct them to the panel of all three, the chairpersons and the speaker.
Thank you. Thank you. I hope I am visible and audible.
Is it for us? I mean,
Vasu and Dhruv Singh, yeah.
I think Unni's session is the next session. Sorry, Unni, we have a small role to play here. Just to basically sum up what Shawal just spoke.
Sorry.
No problem. In fact, today is a Saturday night, so the spirit is very high. I think, you know, those classic words that a man walks into a bar, this kind of introduces a very kind of a countless humorous situations after that. But when we say that a man enters a hospital, unfortunately, these words introduce to us a very distinctly serious situation. And we know that this talks about people's lives, which too often includes mistakes, misadventures, and also in our kind of settings where we are trained well, that might include preventable deaths. So hospital, we all know, is a dangerous place. Approximately 1/3 of all the deaths that happen in any country is at the hospitals. So we must be careful about knowing what are the basic steps that we must take. So among hospitalized patients, both hyperglycemia, hypoglycemia, they are all associated with adverse outcomes, including death. Therefore, careful management of these patients with diabetes has direct and immediate benefits. And we know that hospital management of diabetes is facilitated by, as Dr. Chandalia clearly said. Let me say, Dr. Chandalia sounds, I mean, Shaivala is a better name to choose as a good friend and a brother. The pre-admission treatment of hyperglycemia in patients having elective procedures, that is something that we need to devise and apply. We need to have a dedicated inpatient diabetes service team applying well-developed standards, what the different protocols or our indigenously developed protocols over the years. And finally, we need to actually take care of that careful transition when the patient is going out of the hospital to a pre-arranged kind of an outpatient management setup. So these steps will also always, beforehand, if you do this, it will shorten the hospital stay and reduce the need also, when you do it better after discharge, the need for readmission. So finally, of course, a better patient outcome. So what is very important, I mean, I think Shalal has elucidated on every point that we need to know about a patient in the hospital. But I would just briefly tell and add here that the three settings that where we need the regimens, including insulin analogs and whether or human regular insulin for good control, is that the use of subcutaneous rapid or short-acting insulin before meals for every, whether it's every 4 hours, 6 hours, that's how we do it for our CABG patients, because I'm in charge of the cardiac setup, or the operative setup, if no meals are given to the patient. So if the patient is either receiving continuous enteral or parenteral nutrition, and that is how we do it. Basal insulin or basal plus correction regimen, only correction regimen, is the preferred treatment for the non-critically ill hospitalized patients with poor oral intake or those who have restricted intake. And an insulin regimen with basal, prandial, and of course the correction components is the preferred treatment for all the non-critically ill hospitalized patients with good nutritional intake. We have to understand and remember that the insulin injections should align particularly well with the meals, and we need to also have these point of care glucose testing performed very regularly, exactly immediately before meals. And if the oral intake is poor, a safer procedure is to administer the prandial insulin immediately after the patient eats. In fact, our old Novorapid, Humalog, and now the new one, Fias, they all suit the purpose well. So these are the points we need to highlight to our audience, making sure that they remember this. And the basal bolus treatment is always the best because, compared with the reactive or the sliding scale, that roller coaster insulin regimen and the glucose excursion in even general surgery patients with type 2 diabetes. Prolonged use, you can do a little bit of sliding scale initially for the first 2-3 days post-op, but prolonged use of sliding scale as a sole kind of treatment for hyperglycemic inpatients should be strongly discouraged. And we also now know that the premix, NPH 70, regular 30, can also be given in cases with this kind of a setup, but we only have a little bit of more hypoglycemia chances, so therefore we don't recommend this. But it is not that you can never use this. The way we were trained that you can't use premix is not sacrosanct. We have seen time and again that they can, if you are titrating well with your POC glucose testing, this is good enough. So after a fantastic talk, I think the transitioning of the intravenous to subcutaneous insulin, etc., that is a completely different workshop or another module. So we have a lot of things to talk about in this kind of a hospital setting. Already, Shalala has talked about the non-insulin therapies where DPP4, GLP, they can all be continued, but make sure that the patient has a cardiac problem, then Saxa should be avoided. Avoided in the sense because of the SAVOR-TIMI results, but not for any other issues. And SGLT2 inhibitors, after the DARE study, even perhaps people have become very enthusiastic about writing a DAPA.
5 minutes left for the discussion.
So I'll just hand it over to Dhruv. So whatever said and done, one very important point is we must take care of the hypoglycemia part when we are talking about insulin. So a plan for preventing and treating hypo should be established for each patient, perhaps. That's the best recommendation, if you can do it. When there's a less than 70 record that is documented, please make sure that we go and delve deep into kind of investigation why it all happened, and that can give us sort of answers. And we should not ever let that hypo repeat again. So this is kind of the fundamental understanding of insulin in this kind of a setting. So over to you, Dr. Dhruv.
Thank you, Devashish. I think we have made very valid points. Just to add a few bits and pieces here and there. Now, what we normally see is that in spite of so much of awareness among the treating physicians, there is still a big need for the hospital staff to identify elevated blood glucose levels in all hospitalized patients, because not always it happens that we know that the patient has got diabetes. And what happens is a lot of patients, they may have stress hyperglycemia. So it's very important that the staff is trained to identify these patients who may have elevated blood glucose levels. Also, there is a need to create proper educational programs for the treating staff so that we can have the training, and at the same time we can have sort of a proper plan for these hospitalized patients, wherein we categorize them into terminally ill or those serious and non-serious patients, and accordingly we develop a plan for glucose management. Third point which I would like to make here is often the list of medications with which the patient may walk in. The patient may not remember all the medication what he or she may be taking earlier. So it's very important for the medical team to go through the list of medication in person so that they can be aware that which medication may sort of contribute to hyper or hyperglycemia, and may sort of, because of this polypharmacy, it may be very, very important for the treating patient to know that which medicines to avoid. Finally, when it comes to the transition from the hospital setting to clinic, it's very important that a subcutaneous dose of insulin is given before the patient is discharged, and the patient is made aware that no, this is going to be your new dose, and we have stopped the insulin now. We have given you a shot of subcutaneous insulin, and what is your new dose going to be, and how to manage hypo or hyperglycemia in the next few days, when to contact your doctor, and sort of a small diabetes education for the patient as well as the carer of the patient. I think it helps in the long run. These are my few words. Let's see if I've got some questions in the box.
I think there are some interesting questions from the audience in the chat box. So 2 questions from Dr. Walter Di Mello. One is, what is the effect on insulin doses in the hospitalized patients with critical infections? And secondly, how do you find out insulin resistance in the hospitalized patients? So the panel and the speaker to answer these 2 questions.
The first question is that in a critical infection, the blood glucose usually goes up and the insulin requirements go up, especially in sepsis, in the ICU. There are conditions like septic shock, for example, severe septic shock, when your blood glucose can actually drop, and that is the condition where you have to be very careful about using your anti-diabetic agents. So I would say in general, the requirement usually goes up, but it can drop also in certain situations.
And how do you recognize insulin resistance, or how do you guess that a given patient will require a lot of insulin?
So like I said, there were certain conditions like, of course, obesity, for example, or use of corticosteroids, or post-renal transplant, again, where multiple steroids are being used. These are conditions which increase insulin resistance. So your starting point can be much higher than if somebody who did not have, for example, either obesity or, for that matter, use of corticosteroids. So I would say, depending on the clinical situation, you can start at a higher dose. You can also link it to the patient's pre-hospitalization dose. For example, if the patient is already on 40 units of insulin, as an outpatient, then it would not make sense when you give correction doses to give like 1 or 2 units of correction doses. So you should link it to the pre-hospitalized dose. And also in certain situations like obesity, corticosteroids, you use a much higher dose than you would normally. I don't know if Dr. Basu or Dr. Singh would like to add anything.
Yeah, I mean, you're absolutely right. I mean, any critical illness means insulin resistance. All the counter-regulatory hormones are overexpressed. So what I think sir wants as an answer, if I'm allowed to say this, that the patients who develop extreme insulin resistance are defined as having insulin requirement of more than 3 units per kg body weight. So if over the 1 day or 2 days time, if you realize that a 70 kg old man, weighing man, he requires more than 210 units of insulin, then we realize that this is a case of insulin resistance. And perhaps in these cases, now the new closed loop hybrid system is being brought into use. And initially they are made to understand that they're put into kind of this basal bolus, typically artificial pancreas method. And if they can continue this, well and good. Otherwise, when they're out of the crisis, the whole thing reduces by almost 50%. So we know that this is a clinical dilemma. We have to very safely and very effectively manage. But the target, that is more than 3 units per kg per day, is the insulin requirement, which will identify the patient as insulin resistant.
The time is up.
Debashis has nailed it very well. I think that's one of the best way to recognize a person with insulin resistance in the hospital setting.
A question by Dr. Kadlur from Pune. If we require to give larger doses of insulin, say 40 units every time, is it advisable to give half the dose in 2 sites? Giving it in 2 sites, will it be a better guarantee of insulin delivery? So I'd like the panel to answer.
I
So
think that
40 units is, oh, sorry, go ahead.
so 40 units, I would say probably given the same site, because your absorption kinetics at each site is different. So if you give 20 units here and 20 units in another kind of place, then there could be two different absorption kinetics, and that will actually cause more confusion. Sometimes
In fact, routinely it is said that for till 40 it is good enough for a generalized, the pharmacokinetics to behave well. 40 units is acceptable. It is acceptable. But beyond, say, you need 60 units of lactose or 80 units of basal, then you should divide it ideally in the two parts of the abdomen. That's what you are saying, that it's the same surface area or the same site. Abdomen should be abdomen, leg should be leg, so that the glycemic intraday intravariability is less.
So time is up for this session, sir.
Thank you very much, the panelist speaker and panelists. And now, are we through, Dr. Pandit? Time is up?
Yes, absolutely, sir.
Okay. So we move on to the next session, which is on insulin therapy in type 1 diabetes. And the speaker is Dr. Archana Sarda. And the chairpersons are Dr. A.G. Unnikrishnan and Dr. P.G. Talwalkar. The time allotted to them is shown here. I'll present the CVs of our chairpersons, Dr. Unnikrishnan. He is CEO of Chelaram Diabetes Institute, which many of you might have visited, a state-of-the-art diabetes institute in Pune. And he is there since almost its inception, or after about 3 to 4 years, the institute was started, and he had developed beautiful diabetes care at the institute and in the outreach rural areas, which I think is very important to see. And he's conducting those programs. He's editor-in-chief and founder editor of Journal of the Thyroid Research and Practice, and executive editor of Indian Journal of Endocrinology and Metabolism. Our next chairperson is Dr. Pradeep Talwalkar. He's consultant diabetologist at SL Raheja Hospital, Mumbai. He's diabetologist at Sushruta Hospital, SR Mehta, and Dhanvantari Hospitals. He's a postgraduate teacher in diabetology at the Maharashtra Health Sciences University. He is honorary professor of medicine at Grand Medical College, and he was associated with St. George's Hospital and Grand Medical College, and associate editor of ABI Textbook of Diabetes. The speaker is Dr. Archana Sarda, consultant diabetologist, looking after her center in Aurangabad. And she's founder of a very important initiative called UDAN, an NGO which looks after underprivileged children with diabetes. And currently, in associated with RSSDI task force, she is the main convener for starting a task force for care of type 1 diabetes under the aegis of RSSDI. So she's the leader there in making this great initiative. 20 years of work in innovative diabetes care in rural and low resource setting. I would now request Dr. Archana Sarda to present her talk on insulin therapy in type 1 diabetes.
Thank you so much, sir. Good evening, everyone. Good evening, chairpersons. It's a pleasure to be here. I'll just share my screen.
Sorry to interrupt, Dr. Sarda. Can you please remove your virtual background, as your internet connectivity is weak and it may take extra bandwidth. So I would request you to remove your virtual background.
How do I remove it?
I'll
I'll just do that. Is it visible? Am I audible?
Yes, please go ahead.
Good evening, everyone. It's a pleasure to be here. The topic today in this insulin symposium in the centennial year of insulin discovery is insulin therapy in type 1 diabetes. At the outset, I would like to state that in fact, I would like to humbly accept that I am going to speak at a very basic level with the thought that the audience is physicians, and over 20 years, especially as Sir mentioned, now that we have started the task force, we have realized that every physician sees very few people with type 1 diabetes, either children or adults, and hence a lot of myths in initiation and the type of insulin and actual need of insulin being there. So my basic thought would be that. So I would ask forgiveness of all people who are actually experts in type 1 diabetes for a very basic talk. But I feel this is very essential, and the driving thought behind the insulin project and the task force work that we are doing. So the first thought, which goes without saying, but is very, very essential, and that makes it different from all the other topics in the last two symposiums in this symposium, is that a person with type 1 diabetes, it's not a choice. So it cannot survive without type 1 diabetes. And this is something which we have to keep in mind, as yet there are myths, there are thoughts amongst the healthcare providers, and it's very, very essential that we take it forward. So not only is it essential, it is also the right of a person with type 1 diabetes, whether a child or now an adult, to actually have that insulin. So if a person cannot afford insulin, it's very important that we as a physician direct them to a source, a resource where they can actually obtain it. So not only is it their survival kit, it is also their actual constitutional birthright. And in that, with that frame of mind is how we will approach the insulin therapy in persons with type 1 diabetes. So now we all know about the natural history of type 2 diabetes, but in type 1 diabetes, it's very important to realize that we rarely get to see our patients at the early stages where the beta cell mass is adequate. So at the genetic predisposition level or the immune dysregulation time when it starts, or wherever the environmental triggers have actually come in, or a pre-diabetes. This sometimes does happen with more awareness and more screening, maybe where there is a family history or great awareness in the family. But even so, we all know that in our clinics, we often get a person directly in diabetes ketoacidosis. And the purpose of showing this is also that when that onset is there, we ought not to delay our therapy at all. Because if we already are in a stage, and if we take a few days to decide what to give and what not to do, whether to give insulin, then there's no point in all this early detection. And by the time we take a decision, the child or the person has already landed in ketoacidosis. So what could have been managed in a OPD basis or at home or in a ward now becomes a ICU setting situation. So it's very, very important that we treat as early as we can detect, and it's already the situation has been created when the child comes to us. So the pathogenesis, we know, we have been talking about it in the last many sessions, is that following a meal for the postprandial, the energy released from the ingested food for immediate use, right, and stored as glycogen in liver and muscle, any excess is deposited in the adipose tissue. Anabolic steps are carried through insulin secretion and action. In the fasting stage, sleeping in the night, insulin levels fall, it is a catabolic state, mobilization of energy from the stores. Why I mention this is because in type 1 diabetes, because as physicians, we are all used to type 2 diabetes. So keeping that in mind is that in absence of insulin, the peripheral utilization of glucose is halted, and there is postprandial hyperglycemia. Now, low plasma insulin leads to catabolic activity in liver by glycogenolysis and gluconeogenesis. So there's endogenous glucose production, and hence there's this fasting hyperglycemia. Now the counter-regulatory hormones are at work, so inducing glycogenolysis, gluconeogenesis, lipolysis, ketogenesis. All the growth hormones, cortisol, epinephrine, they are going to oppose the action of insulin. and decrease the peripheral tissue utilization of glucose and glucose clearance. Again, elevated blood glucose level. So whichever path we have in a person with type 1 diabetes, there is hyperglycemia, fasting as well as postprandial. Now, what are the goals of insulin therapy in type 1 diabetes? I am not going into the details of insulin because we have been covering that in bits and pieces in all the talks of this symposium, and in specifically a person with type 1 diabetes. So to achieve near normal blood glucose levels at all times in an as physiological manner as possible without causing hypoglycemia. So we do always talk about near normal blood sugar levels without causing hypoglycemia. But in this case, it is also as physiological manner as possible because the variability, the child is growing. There's so many factors which we will be seeing now. And to ensure a good quality of life and prevention of short and long-term complications. We are talking about a lifetime where insulin is the life component, and hence the good quality of life becomes a very, very crucial factor even in the choice of insulin therapy. So that is the reason I mentioned it here specifically, that good quality of life actually does often depend on our choices of insulin therapy, and those choices can go wrong if we are not aware of them, and being the purpose of such symposiums for type 1 diabetes. So in a person with type 1 diabetes, it's not just getting the blood sugar to become normal. It is also the freedom to not just survive, but also to thrive. This is a picture of the first one-up challenge by 22 champions with type 1 diabetes from across the country who went to the Kalsubai peak and achieved this. Now, many of them were on regular insulins, conventional insulins. Many of them were on analog, and a few of them were on pumps. Some were doing SMBG, some had a CGMS, but all were able to make it. So the importance, again, I am emphasizing here, is the choice does not just bring the blood sugar level down. The choice also has to give freedom, because these are young people, they are growing, they have dreams, they're going to do something in their life. And if they are going to be mentally and socially restricted, then maybe having a normal blood sugar level is not going to be enough. Now, before we go ahead into the actual therapy, there is absolutely no way to have a insulin therapy in a person with type 1 diabetes without education. So that is the essential foundation of successful insulin therapy in type 1 diabetes. I absolutely understand that whether it's in a hospital setting or it is type 2 or GDM or senior citizen, or everyone needs that education. But in type 1 diabetes, it is a lifetime of self-care. We want to empower them, and the only way to do that is with education. So whenever we talk about insulin therapy, we have to back it up with education, which is as good as a prescription of a syringe or a device or a pump or whichever type of insulin we want to use. So today we are going to talk about the intensive insulin therapy. We are not entertaining the conventional insulin therapy, but there will be a reference to that. So in the intensive insulin therapy, by which we mean that we can change our blood as per the blood sugar level. We monitor, we change our insulin doses as per our activity, as per our meal, as per the monitoring, and accordingly take the insulin doses and the type of insulin choices to bring out the best outcomes. So that kind of intensive insulin therapy is what is recommended for best outcomes, and that is what we see. We have been all here, we have been seeing over the last few decades, and a wonderful change has come with the intensive insulin therapy. So the advantages are, it's a more rational control of blood glucose with the ability to adjust insulin doses to diet, activity, and illness. For example, the students who went to the challenge, one-up challenge, if they are to climb a mountain, they have to be able to adjust their doses. They have to be able to skip a bolus if they have had activity beyond their routine activity. They have to be able to measure and accordingly adjust their doses. This is only possible if we are using an intensive insulin therapy model. Now, the delay in onset of progression of retinopathy, nephropathy, proteinuria, microalbuminuria, neuropathy, all complications are delayed or prevented with intensive insulin therapy. Reduced risk of hypercholesterolemia and hypertriglyceridemia is seen with good control, improved sense of well-being. This is something, if you experience, if you have a patient on conventional therapy, just because they want to avoid pricks or it is less expensive, I can totally understand that. But when they are shifted to the intensive insulin therapy, the well-being, the mental, physical well-being is so almost tangible. And that itself is a outcome that we desire. Decreased fetal and maternal morbidity during pregnancy. And now more and more survivals are high. In my own clinic, I have 70 young girls who have become mothers. I mean, the mothers are type 1 and with all good outcomes. So this is possible with intensive insulin therapy. The disadvantages are, of course, there's a increased episodes of severe hypoglycemia, which is why it is feared. And there is always a thought of weight gain because there's freedom to eat, there is more insulin taken, and especially in the adolescent age group, we find that they do have more weight gain with this therapy. It is a lot of time, effort, and cost. I think that is the biggest disadvantage. I wouldn't call it disadvantage. It's the biggest reason it is not actually being carried out is a lot of time, effort, and cost that goes into intensive insulin therapy. It is also very difficult to practice it in young children, especially the ones who cannot take care of themselves, say less than 7 years of age. But the availability of monitoring systems. Now we have affordable SMBG. Glucometer strips are no longer very expensive. The monitoring can be done in certain patterns, can be done multiple times, and CGMS is available, which can be done in a diagnostic way or a continuous way, always. And these new delivery devices, this is not what I'm going to talk about, such as insulin pumps, which is the next topic, has made it really possible to provide this therapy very, very safely. So we all are aware of the types of insulin, but in context of type 1 insulin therapy, it's very important for us to be able to visualize what is the insulin choice that we are making and what is it going to do in the regime of a person with type 1 diabetes, because this is a replacement therapy. So we are using only insulin, and hence what we would be considering while choosing is not just the affordability, but also the lifestyle. If a child is going to school, the meal patterns, the activity patterns, the proneness to hypoglycemia, so many things. So what are the choices we have? So these are all, actually it's a treat to have all these choices. Earlier we didn't have them. So very rapid acting insulin is 5-ASP, which is actually aspart with B3, which makes it act even faster. So the advantage here, I would just like to very shortly mention itself is that especially, it can be given after a meal. And when you have little grazers, kids, and we do not know what are they going to eat, how much are they going to eat, it's a blessing. And if you have ever seen a mother, ask them, and they feel so relieved if they can actually give the insulin after the meal. Then we have the rapid acting, we will be talking about them. We have the regular insulin, which we have had all the time, intermediate acting NPH, which is now available, the only one which is now available, and the long acting glargine U100, Detemir, and the very long acting degludec and glargine U300. So with this whole basket available to us, just knowing its physiology, we can tailor make a regime for a person with type 1. In fact, a person themselves, they can manage their own regime if their lifestyle changes, if we educate them enough. The other options are, of course, the biphasic insulin, whether it's analogs or non-analogs. So we have these combos available, as well as with the long, and so co-formulations are also available. So we will be talking about them. Here I would like to mention that it's often seen that it's easiest to prescribe a premix twice a day. And that is the commonest prescription I see for any person with type 1 diabetes who comes to me when they come from wherever they come from. So that is something we want to talk about. I'm not saying it's absolutely not to be done. I would not do it. And I would try to find, if cost is the issue, then I would find a way to find more physiological care. So this is something we all know, but again, from a point of type 1 care, I would like to emphasize again that if we have a similar chart in our clinic and we explain it to our patient, I have found that even the children and their parents from villages, when they see such a chart and they realize that their insulin is not working for 24 hours, there is an overlap, right? Because NPH and long-acting, for example, glargine, and when we see this, then they actually interpret this graph to beyond our expectations. We don't really realize that they are so able to absorb it and relate it to their own life. And similarly, we have the rapid acting insulin and the short acting insulin profile, which we are all aware of, and the premix insulin and the premix analog insulin. So with these kind of profiles and keeping the physiology in mind, what are the insulin regimens that we can offer children or adults? Now we see also adults with type 1 diabetes, and what can we offer them? So short-acting insulin, of course, is used during the DKA time and during the sick days as supplements. But for day-to-day management, it has to be both. Now, I know it sounds very basic, but I do get a lot of referrals where the child is just on short-acting insulin. So just regular insulin 3 times a day. There is no basal given, or premix twice a day, or just NPH. So there's all kinds of treatments being given without the understanding of what is required in a person with type 1 diabetes, because in type 2, that still works. It doesn't let a person collapse. But in type 1, it leads them to ultimately land into ketoacidosis, hospitalization, and everything else. So the 2 regimens which are basic in India, we're not, the pump of course would be the way basal bolus is given in the technology, is the split mix regimen and the basal bolus regimen. So let's talk about the split mix. So I am now talking about the commonest thing which was done, which was 2-dose split mix regime in type 1 diabetes. So please look at this graph, and this, if we look at the NPH, and you have the regular plus a NPH. So most people would just give it mixed with breakfast, a regular and a NPH, regular and a NPH. But as we can see, what is happening here? So even if we replace the regular with a analog, suppose it was a rapid acting insulin. So look at this, the lunch part. The breakfast is covered, but the lunch is not covered with the analog insulin at all, but even with regular, it is not covered. And there is a peak of NPH in the evening where there is no meal usually, and there is hypoglycemia. So the morning NPH is giving a hypoglycemia in the evening, and the regular insulin, the short-acting insulin, is not covering the lunch peak. So the child has hyperglycemia at lunch and hypoglycemia in the evening, and maybe at school as well here. Another thing is the NPH. Now the NPH will have dropped somewhere in the night, and there will be a midnight, because it's peaking there, would be a midnight hypoglycemia. So this is extreme variability. Today we talk so much about glycemic variability, and this is a lot of variability, which is not obviously the best way to treat a child, especially a growing child with type 1 diabetes. So what can be done? As I mentioned also, the other aspect is that the regular insulin is given 20 to 30 minutes before the onset of meal. Can you imagine a child who would take 30 minutes before a meal and wait for 30 minutes and then eat? I mean, just how difficult could that be for a child, if at all there was an option? Another thing is in school. So often in schools, we ask them to take analog.
Dr. Archana, 5 minutes to go.
Yes. So regular plus NPH poorly mimics the normal endogenous insulin secretion. So that is something I would like to emphasize here. And if we can, what can we do? If we have to use the conventional insulins, just add a short-acting insulin at pre-lunch time and regular insulin 3 times a day before each major meal, and NPH insulin only at bedtime or preferably pre-breakfast plus bedtime. So if we look at this last one here, this is a way we can use conventional insulins with 3 regular insulin and NPH at bedtime or NPH at breakfast and bedtime, and yet bring down the cost but not make it a split mix or a premix. Now we're talking about basal bolus therapy. A lot of talk has been done on that, but for type 1, this would be probably, this is the best way. So more physiological, in good monitoring is needed, and carb counting would make it optimal. So just the short acting or rapid to cover the meals and a basal analog to provide basal. That should not be too difficult to prescribe, to buy. It's not that expensive, and making it available is very important. So easy titration, flexibility, low glycemic variability, and a tight control with minimum hypoglycemia is what we achieve. So I've already mentioned rapid acting versus regular, what is the advantage, and long acting versus NPH, what is the advantage. Now, when we actually choose, it can be per the age of the person, the stage of diabetes, financial conditions, school timings, motivation level, and feasibility of giving multiple shots. Yet pre-mix twice a day or 2 fixed regimen is not an option. And last but not least, in the therapy, it is very, very important to remember there would be a honeymoon phase, which will be due to the residual beta cell function. And at that time, the doses would reduce and there will be a very high chance of hypoglycemia. So one must watch out and more monitoring is needed. Similarly, Dawn phenomena and Somagive phenomena can be confused. Hence the monitoring, if possible, CGMS or 3M sugars would clinch the diagnosis and give the right treatment. So, and my last part of my talk is that in insulin doses, it's a big topic by itself, and right insulin at the right time, this is the kind of calculation a person with type 1 diabetes does, and it's a huge task. But our job, first level, is to give the right insulin at the right time to a person with type 1 diabetes. Wherever something is not available, just innovate. For example, this is an insulin pot we created for storing insulin in rural areas so that they could take care of themselves. Thank you so much.
Thank you, Dr. Archana. May I now request the chairpersons and the speakers together to initiate the discussion, and as soon as some questions appear on the chat box, I will direct them to all 3 of you.
Thank you, Dr. Archana, for a very lucid presentation. I enjoyed listening to you. And on behalf of both myself and Dr. Talwalkar, I congratulate you for a marvelous presentation, and it shows the genuine work that you have been doing for years. Could you, from my perspective, could you share some insights of, you have been doing rural work on young type 1 diabetes. Can you share 1 or 2 anecdotal cases which illustrate both the challenges and the solutions in managing type 1 diabetes, especially in the low resource settings?
Thank you, sir. In low resource settings, whatever is missing, there are 3 things which are missing. One is literacy or academic education. The other is money enough to buy the best insulin and enough strips to monitor. So with these 2 limitations, what can compensate and what we find has compensated is education. So we have children who are wanderers, who contract laborers and the ones who take Guy and all those animals across they travel everywhere. And yet having a 24/7 helpline where they can call up after they check. So I feel being innovative in a rural care setting, obviously we have to fit into their budget. So we use regular conventional therapy, but not in a conventional in the sense of a premix, conventional in how they can mix it and convert it into a basal bolus of conventional insulins. That is one. Second is storing it in a pot and keeping it well. And the third is a monitoring pattern. So something which we created for them was a 1+7 pattern. Suppose they can just do 1 sugar a day. Then which sugar would it be? It would not be the same sugar, because often people would come with just fasting every day, which doesn't give insight. So I think innovating to a minimum care of insulin, monitoring, storage, and having a helpline, because this is something which is very, very important. And we are able to find we hardly have children getting admitted with ketoacidosis because of this.
Over to Dr. Talwalkar. Sir, if you have any comments, please. I think your mic is muted, sir.
Please unmute yourself.
I have a couple of questions for you, Archana.
Yes, sir.
You stressed on patient education or self-education, which is extremely important, and it is actually a fourth cornerstone in management of diabetes, along with insulin, diet, and exercise.
Yes.
So do you have some kind of structured program where there is some sort of a follow-up? You find out how much they have learned by asking them questions?
Yes, sir.
What kind of
In our center we do,
program?
and we do at our center, but in very soon and through the RSSDI task force, we hope to make it available to everyone very soon. But in Udan, where we are doing this, we have a kind of a very structured induction program. So when a child comes in, the first 6 visits are called induction program. And that is one-to-one teaching where every topic is demonstrated, taught, seen again whether they have learned it. And out of the 6-week program, some people take just 4 visits, some take 6 visits, but then there's a kind of an exam. I mean, it's not really an exam because many of my children are not literate. They cannot give a written exam, but a practical kind of exam. And if they do well, we have a 100-point FAQ. So once we do that whole thing, then they are moved to the other group. So they feel they have graduated, from an induction program to a graduation program. We give them a hat or something. Now they know the basic care. So basic module is ready. And that is something we hope to roll out with the RSSDI task force as well. I would just like to add here that it just takes a lot of educators. I mean, education is important, but who will do it is a very big question. Where is the time? Where are the people? So I think the major link which is needed is people who will educate them to create more and more.
Do you have some programs to train the trainers in your setup?
Yes, we do. We call it a D-Mom to D-Coach program. So because qualified educators are few, I have only 2 qualified educators. So we train the mothers of type 1 to become coaches. And this is something in the task force, we are looking at educator programs through RSSDI, and we're looking at coach program, patient program, and doctor training program for physician and pediatricians. So very soon, before this, maybe next few months, we hope to roll it out for the entire nation to be able to reach out to the last mile.
Here I would like to quote Dr. Elliot Jocelyn, who made this statement around 1935, that he said for the patient, those patients who learn more about diabetes will live longest by avoiding complications. So this is an important statement. And other question I would like to ask you, the other end of your spectrum of patients where you also treat educated, wealthy people, and you are using a lot of insulin pumps. So I would like to know about how much is the difference of HbA1c you're getting between the pump-treated patients and intensive subcutaneously treated patients. And is there any trial in the world where they have documented that this was the difference at the end of a long-term period, and that resulted into this much lesser vascular complications? Of course, only microvascular. At that stage, you can't see macrovascular. But to the best of my knowledge, that kind of study with a clear-cut reduction in the microvascular hard endpoints is not yet available. You are doing more pumps than me. So can you throw some light?
5 minutes more for discussion.
Yes. So I think as you rightly said, sir, there's no study that I know of, at least, which is clear-cut hard endpoints. But in our own experience, also, it is more of the motivation and how you use it. So a person who is knowledgeable and motivated and using basal bolus with the injections is at par with a person on a pump if the pump user is not using all the facilities available and is not, that motivated and educated. So ultimately, it boils down to the knowledge and motivation of the person who is using either basal bolus with injection techniques or the pump. But pump users who are motivated and intelligent enough to focus on carb counting can have achieved amazing results. I do not have a study to show enough comparison, but they are able to have such a flexible lifestyle, like running marathons, doing the Everest camps. So that kind of lifestyle is just possible when they are on the pump and CGMS. So that is the freedom to achieve whatever they want. There's an Iron Man who has done this. So that technology has an edge which we cannot get with just our basal bolus injection.
There's a lot of proof about immediate improvement in a lifestyle, the quality of life, but the long-term proof is still lacking.
That
Dr.
will take
Unni
time.
Krishnan, can you throw some light on it? Your experience at Pune,
My,
or your experience of reading the literature?
So my experience is that, the best, of course, if somebody can afford a pump and a CGM is the best. Number two is having a pump, and first is a pump and a CGM.
Yeah.
Second is, I think, a CGM and multiple daily insulin injections.
Yes.
The third would be pump and SMBG, and the fourth would be SMBG and multiple insulin injections. So this is somewhat at odds because everybody feels pump is the most superior. But I think pump is the most superior only if you have a CGM. And if you have a CGM with multiple injections, and there's a study which showed this. I think it was a Commander of the Commodore study which showed that having a CGM with multiple injections is superior to having a pump and SMBG. I wish there were a more economical CGM for use in a country like India, because the sheer magnificence of diabetes as a disease burden coexists with ground realities such as affordability and accessibility.
True. But CGMS is really a game changer, even diagnostic CGMS. Even our rural children, we try to give them a CGMS at least once in 3 months. And that itself has shown so much improvement in the way we can manage them. But I would just like to add one thing, that often we find the missing link is also the doctor's inertia and knowledge and interest in type 1 diabetes, because I realize that there are very few patients per doctor. So our whole initiative now is going to be a drive where doctors themselves are as aware, even if it is just one odd patient in their clinic.
More power to you, and wish you all the best on that.
Thank you, sir.
Would you like to take a few questions from the chat box, please, to the panel? There are two questions, one by Dr. Arun and Dr. Kadlur. Both are related to Ryzodag. So do you think this formulation, 2 injections a day, will give good control in type 1? And whether in basal bolus, instead of 4 shots a day, obviously you might get away with 3 shots. So I would like the panel to answer these questions related to this co-formulation.
So co-formulation is a fast-acting as well as a long basal. So basal component would obviously be well covered, but the rapid-acting, the prandial insulin will cover the meal that they take it with, the breakfast or the lunch and the dinner. So there'll be one meal which is still uncovered. Second thing, which in any co-formulation or pre-mixed insulin, is that it's a fixed dose. So if you just need to take care of only fasting hyperglycemia or post breakfast or post lunch, that is something which will not be titratable. So it is always best, it's just one prick less. So in a person with type 1 diabetes, the same
How often do you get away with 3 shots basal bolus by using this Ryzodag? Do you have to again give the rapid acting at dinner?
Yes.
At least more than half of my patients I had to add rapid acting at dinner.
Yes, mostly in type 1s. Only if they have a very rigid type lifestyle and lunch is just a salad. There are some people who would do that just to skip one insulin shot. But otherwise, it's very difficult.
A question by Dr. Vach Rajani from Mumbai. How much maximum insulin can you use? As much as it will control diabetes.
As much.
How much is the maximum lifespan of a type 1 diabetic patient? I think I'll add to that later on because my lifespan has been long, so I can. But Archana, in your group, who is the oldest? What is the oldest?
My oldest one has 45 years of type 1 diabetes.
I got one 85-year-old type 1.
Wonderful.
A few of them. And one of them on pump for 40 years, by the way, without any complications. So that is anecdotal. What Dr. Pradeep Talwalkar asked is very important. Is there a long-term study comparing MDI multiple doses with pump. And I think it's very right. Long-term study, I've not seen any. But I think next pump session we'll pose this question again. Meanwhile, we can take
time is up.
Couple of questions. Is there time?
Yes, sir. Time is up.
Okay. All right. I think we'll have to abide time. So thank you very much, all three speakers and panelists. And we move on to our next session of the day. Okay.
Thank you.
And the next session is on insulin pump therapy. So I think some of those questions could have appeared here. The speaker is Dr. Jyoti Dev Keshavdev, and chairperson panelists are Dr. Bansi Sabu and Dr. Sunil Jain. Let me introduce our chairpersons. Dr. Bansi Sabu, she runs a good center, diabetes care and hormone clinic in Ahmedabad. She is president of RSS DI just last year, I think. And a whole year he was engaged in initiating many new programs under the RSSDI banner. One last one we talked about was the type 1 diabetes program. He's active in diabetes in the Asia study group, and of course he's been acknowledged as a wonderful field worker in diabetes, editor of Sadicot International Textbook of Diabetes, and advisory board member of JAPI and Journal of Diabetology. And our other chairperson, is Dr. Sunil Jain, DM from PGI Chandigarh, and runs a beautiful youth center in Indore called Total Diabetes and Hormone Institute, where he, besides treating patients, he has a great training program there, which I witnessed several times. Major interest in technology solution in diabetes, and he is one of the pump users. And it was a nice book, you know, how to get the most out of your pump, contributed chapters to many textbooks and all. And our speaker of the day is Dr. Jyoti Dev Keshavdev from the Trivandrum, Kochi, runs his own center. You see, he was being the managing trustee of Keshav. The trustee is a very literary trust because his father was one of the great authors, writers in Kerala. And RO is Obesity Association. He's been active there. You see, telemedicine, the technology he's interested in, and he's also a great pump user. So we have 3 pump users in this pump session. So over to our speaker. The time that is allowed is given here on the screen, and I would invite Dr. Jyoti Dev to initiate his talk.
Thank you very much, Chandaliya sir. And congratulations for this very unique program. And I will admit that Chandaliya sir only introduced me to the science of diabetology, and that is a long story. So thank you very much. So let me share my slides. So along with us, there are 2 stalwarts, Dr. Sulam Jain and Benchify, who are also insulin pump users in the country. So my duty in the next 15 to 20 minutes will be to briefly go through the evolution of insulin pumps, especially in India, and the types of pumps which are available in India. And I'll be discussing the upcoming insulin pumps and the developments in the insulin pump technologies. So when we go back to the history on where exactly this technology started, and I meant the modern day insulin pump therapy, it all started in the year 1979, when there were 2 simultaneous publications from John Pickup and Tamberlane, and they were discussing on the feasibility of continuous subcutaneous insulin infusion. And often John Pickup, and this is a picture when he was there at our convention in Trivandrum in the year 2018, and John Pickup is regarded as the father of modern day insulin pump therapy. Insulin pumps can be broadly divided into 2. One, the conventional insulin pumps, and these are the insulin pumps which have those infusion sets, the reservoir. So multiple components are there, and these are the insulin pumps which were commonly used all over the world, and the only pumps which are available in our country. The second will be, the other variety of insulin pumps will be the patch insulin pumps, the prototype being omnipod. And these are otherwise described as the tubeless insulin pumps, which doesn't have any tubes or strings attached. And you can see that the reservoir and the rapid acting insulin, it is there within the pump component itself, attached to the skin. Why do you require an insulin pump? So we were a while ago listening to Dr. Archana Sarda, and they were all describing the necessity for a better insulin pump or an insulin therapy in type 1 diabetes. So we require insulin pumps for an advanced delivery or as an advanced gadget for delivering insulin. And the insulin pump, we are using only one type of insulin, and that is rapid acting insulin, which is similar to the insulin which is produced from a healthy pancreas, so that it is mimicking the delivery of that of a healthy normal pancreas in response to the changing requirements. And the same insulin is going to provide both basal and the bolus. And the insulin pump, again, the major difference, one more difference will be, in contrast to the syringe or insulin pens, there can be different basal rates. And this is to overcome the Somogy, the Dawn phenomenon, and so on. And typically, a type 1 patient will require 4 to 5 different basal rates per day. And some of them will require more number of basal rates. And this is the picture of the first insulin pump, the concept of the first insulin pump. Historically, that was in 1963. And this is Dr. Arnold Kadish. In the 1970s, when biostatin was commercially made available, everybody all over the world believed that this is going to be the closed loop system for automating the delivery of insulin without a hypoglycemia. And of course, it was possible. It was made possible. However, the same experiments couldn't be replicated outside the hospital in the free living environment. So commercially, the modern day insulin pump, which one is the first? So historically, I would say that the first pump was launched from Asia, from South Korea. And this is the Suil pump, the Dana insulin pump in 1979. And a couple of years later, Minimed introduced in 1983 the world's first documented insulin pump. So when I say insulin pump, which is documented, even when you look back to some of those manuscripts written by us, we have documented Minimed as the first insulin pump. Since this has been part of even the DCCT, one of those landmark clinical trials, which also led on to the popularity of Minimed Medtronic insulin pumps. So let us now come down to our country, in India. Of course, we are all very well aware of the fact that Dr. Chandalia sir has started using insulin pumps long before. And he has patients for several decades. But for our country, officially the insulin pumps were launched in the year 2004, 2005. And the only insulin pumps currently available, they are only from Medtronic. In between, we had Roche insulin pumps, but they were withdrawn from the global market. In the year 2006, we started using the sensor augmented insulin pumps. So this was very close to the automation. So these are partly closed loops. And this is the size of the transmitter. Look at the size of the transmitter way back in 2006. And this was the size of the sensor. Within a year, in 2007, we can see that this has shrunken in size, both the sensor and the transmitter. And for those of you not aware, and for those colleagues who will keep on asking the question on whether insulin pump is something new in the market, this is the answer. Even in our country from 2007 onwards, we do have insulin pumps, and these are the 722 insulin pumps which will display the sensor value on the screen of the pump. And this goes on changing, it keeps on changing once in every 5 minutes based on the sensor values. Of course, these are all very old insulin pumps now. And at those times, it was a necessity. I would say that it was a legal necessity for many of us using pumps in India, since there were several questions, including the questions from the doctors from other specialties, not only from the public. Why do you require insulin pumps? When we have insulin pens in India, when we have insulin syringes in India only for the delivery of insulin, why do you require such expensive gadgets? Aren't they really required or not? And and hence the pump guidelines were an urgent necessity for us. And these were the initial guidelines published in Diabetes Technology and Therapeutics. And here are the guidelines which we published in JAPI. And you can see Dr. Sunil M. Jain, also a co-author of the Diabetes Consensus Group guidelines. And in a couple of years, that is in 2012, we witnessed the launch of EO insulin pump, which could stop insulin at the onset of a hypoglycemia. But that was not the answer. Why should you stop insulin at the onset of a hypo? We should be capable of having technologies which can stop insulin, which can stop an accident, which can apply a brake before the occurrence of a real accident. And this led on to the further advancements in artificial pancreas. And the first one in India, that was 640G. So when we discuss about artificial pancreas, it doesn't require any surgery. And these are a network of products wirelessly connected with each other, which will have a pump and a sensor. So during the earlier panel also, Dr. Unnikrishnan was discussing about the significance of continuous glucose monitoring in diabetes. So the CGM devices used in artificial pancreas should be slightly more accurate and advanced, and the best ones for the best results. But the challenge until date is the controller or the algorithm. So that is the third component, which is the most important component of an artificial pancreas. So 670G came with a smart guard technology in the year 2015. So this was our first patient on 640G. And the 640G was capable of not only stopping insulin. So you have the upper panel with CGM and the lower panel with insulin dynamics. So you can stop insulin before a hypo, only to resume delivery when the glucoses are back to acceptable levels. So moving forward to the closed loop systems. In 2016, Medtronic launched the first ever hybrid closed loop system. So what is a hybrid closed loop system? Hybrid closed loop system will have an automated basal delivery during the nocturnal hours. But during the day, still you have to announce the meal. So manually you have to administer the bolus. So again, the automation is only partial. But still, if you look at the data which is available with 670 users, the mean time spent in range, nowadays everything is, all the clinical data need to be reported in terms of time in range. So the time in range average is 71.3%. So this is 10% better compared to the manual mode of the same pump. So all these pumps will have a manual mode as well as an automated mode. Another hybrid closed loop system from Europe, and this is the Diabloop hybrid closed loop system with a Kelido insulin pump and an Android controller. And most of these systems, if they don't have a sensor, then it is usually the Dexcom sensor. Why Dexcom sensor? Because Dexcom is the most accurate continuous glucose sensor ever produced. But unfortunately, highly priced, prohibitively very highly priced, and not freely available in our country. And soon to be launched globally and expecting launch in India as well. The pump looks similar to the existing pumps, but this is slightly more advanced, and this is 780G. And the launch will be in the very same year, 2021. So what is the difference between 780G and 670G? 780G will be self-adjusting the basal insulin delivery. So the basal will be automated, And the boluses will also be partly automated. So there will be auto correction dosing and will automatically correct the insulin delivery every 5 minutes. And it also helps prevent both hyper and hypoglycemia. And what is advancement? So this is the advanced hybrid closed loop system. So the advancement is again with time in range and reduced time below range. So here we have again advanced to 75% time in range. Remember, the earlier one was 71.3%. Average was 70%. So even a percentage such as 3% or 5% improvement in TIR, it makes a huge difference in the management of diabetes, especially type 1 diabetes, with an overall time below range of 1.8%. And this is the same advanced hybrid closed loop system where you have on the left 2 to 3 hours active insulin time, and on the right I have another data where the active insulin time is reduced to 2 hours, where you have again an overall TIR which has improved from 76 to 79%. And if you look at the overnight TIR, because overnight TIR is the data which everybody is bothered about when the subject is sleeping, and it has advanced from 84 to a phenomenal 87%, and that has been phenomenal. And this is a study, of course, Dr. Benji Sabu was also part of this study where we looked into the overall quality of life. So these were all patients who were on insulin pumps for quite some time, for more than 10-15 years. And most of them reported, majority reported and appreciated improvement in the quality of life. So if you ask a patient on an insulin pump, what is the difference after being on insulin pump? If it is appropriately titrated and programmed, the answer will be the overall improvement. And the majority agreed that the pump met their expectations. So this is a picture of 2D DATs. So this is the terminology which is used in type 1 diabetes, and we are on waiting. So these are the diabetes dads with children with type 1 diabetes. So they have been innovative. So this is a recent development in the last 5 years. The type 1 diabetes community themselves developing devices. So this is Damiano who has created iLet, and the picture is that of the generation 4 iLet, which is independent housing for both insulin and glucagon, with a lot of publications in Lancet, New England Journal of Medicine, Diabetes Care, and so on. And these were the beginning of bionic pancreas, bihormonal bionic pancreas. So what is the benefit of adding glucagon? So they have added desiglucagon in the iLet. So iLet is the name of the device, and Beta Bionics is the name of the company. So automated glycemic control with iLet bionic pancreas. So they have tested with insulin only against both insulin and glucagon. So there was a 10% reduction in the average continuous glucose monitoring measured glucose from 139 versus 149. So for the sake of completion, let me introduce a new insulin pump and an upcoming artificial pancreas. From globally, if you look at the number of innovations and
Dr. 5
publications happening. Yeah, thank you. So there are so many devices coming up in the market. And this one is from Netherlands, a fully closed loop with a bihormonal artificial pancreas. So iLet is not the only one which is bihormonal. So this is from Inreda Diabetic, another type 1 diabetes discovery. It consists of 2 wireless transmitters for obtaining the glucose measurements and a wearable device. And this integrates with the continuous glucose monitoring sensor, and it has also got an accelerometer control algorithm, insulin pump, and a glucagon pump. So these are examples of bihormonal devices delivering both insulin and glucagon. So look at the very recent data. The time in range was significantly higher during the closed loop. So remember, from 70 to 75%, now we have reached 86.6% time in range. time in range with negligible time spent below range. So if you compare the top panel with the bottom panel, so this is the open loop and this is the closed loop. And if you compare the AGP, a picture paints 1,000 words. You can see the phenomenal reduction in the overall glucose burden at the top panel when compared to top panel. So another movement, this is in 2013, the do-it-yourself artificial pancreas. So the type 1 community, the patients and the parents, they are disappointed. So they're desperate with the very slow pace of development of technologies, the highly priced technologies, and the approval from the FDA, which is pending for years together. So they started the movement, we are not waiting. And this has resulted in so many devices, the do-it-yourself artificial pancreas with commercially available pumps, re-engineering the existing and older pumps and connecting with the CGM, and they have the open source algorithms. So this is a classification of the 3 algorithms: Open APS, the loop for the Apple devices, and Android APS for the Android devices. So if you are interested to read more about do-it-yourself artificial pancreas, this is a very recent extensive review from our center, from our centers. So many are involved in this. Dr. Benshibai is involved. Dr. Sheshadri, who is working with us for type 2 artificial pancreas and algorithm development. He is an engineer by profession. And all of us have actually collated the entire data available for building one's own artificial pancreas. And these are all available free from the internet. But remember, these are not FDA approved. So soon we will witness the launch of the new pump in India, that is a solo micro pump with a modular design. You can detach and reattach. And this is going to be the first ever patch pump for India. So this is my last slide. This is again a recent review which we have published on evolution of insulin delivery devices. 100 years of discovery of insulin. So Chandalia sir is to commemorate of discovery of insulin. So we have listed all the devices for delivering insulin, starting from the invention of first insulin pump through FDA approval of T-Slim, which was the first ACE approved insulin pump. So the innovations are continuing. The excitement continues. Thank you. Thank you very much for your patient listening and for this opportunity.
Thank you, Dr. Jyotidev. I would now request the panelists and speakers to initiate discussion.
Jyotidev, it was fantastic talk. And thanks, Dr. Chandalia, sir, for giving me an opportunity, being a chairperson for a very important talk. So I just want, for the audience purpose, as even we know that the advantage of pump therapy is very high. Not only for type 1 diabetic, but also for many of our type 2 diabetic patients who are on multiple daily insulin injection, or a person with GDM or diabetes with pregnancy. Still the usage in India is very low. I agree that the cost maybe is one of the major issue. But do you think, other than cost, what is the major other problem in our country that why usage of insulin pump is not so high? And we know that it's only one company, Medtronic. The other company came in between, they stopped marketing for it. So what is your opinion or your view?
Shifa, is a question directed to me?
Yes.
Yeah. I think the answer I have learned only from you, because you have been discussing in many forums. And I know that you are trying to make insulin pumps more popular because it is something which is absolutely essential for the country. And I remember those days when Dr. Sullam Jain and myself, we used to go around training the doctors. And now I have seen workshops where we are training the doctors on injection therapies, insulin injection therapies, and how to use a syringe, how to use a pen, how to change the needle. So likewise, I think training is continuously required. And during the initial days, I think Chandalia sir used to conduct very, very frequent workshops for insulin pump therapy. And I have been participating in so many workshops initially. And even yesterday I have been telling during a program that for human beings, the next generation will be after 20 or 25 years. But for doctors, every new generation will be after 1 year. So every year there will be thousands of new doctors and a new generation coming up, and they will be completely unaware of insulin pump therapy. So this education training need to be continuous and periodic. Number two reason is insulin pumps are useful only when there is a CGM. So we have been promoting insulin pumps, and many of those patients using insulin pumps probably won't be that happy and not satisfied without either an SMPG, which is so frequent, or a real-time CGM. So now, though we don't have a real-time CGM, of course we have Guardian Connect, and we have a near to real-time CGM such as Libre, which requires a scanning, so it is not a true real-time CGM. But these two CGMs can help promote the insulin pumps in a bigger way. So I think that these two will help promote insulin pumps and CGM in India. It is not the cost. It is never the cost which is a botheration for the doctors and for the patient. That is my take on it.
Dr. Jyotidev, I fully agree with you, but you know, many times the junior doctors to whom we can teach or educate, even by the different platform or by the workshop. But sometimes, I mean, just in the previous talk where Dr. Archana was talking, and one of the questions was that do we have the data of long-term uses of pump reducing? But we all know from the disease trial itself that a tighter glycemic control is going to reduce the complication in type 1 diabetes. And we know to achieve tighter glycemic control with flexibility, with less hypoglycemia, pump therapy or this newer technology. So I mean, there is no need for any outcome trial with the pump that is the microvascular. It is directly a tighter glycemic control is going to reduce the complication. It is not whether you are using pump therapy or you are using insulin therapy. The pump therapy is made for a tighter glycemic control without getting hypoglycemia. And we know from after DCCT, in 1986, there was 60%, 62 per 100 years, there was a severe hypoglycemia, which reduced significantly after 25 years when we started using CGM in 2008. And in 2016, there is a paper from JDRF, only pivotal trial, which had shown 0% hypoglycemia to achieve a tighter glycemic control less than 7. No hypoglycemia, patients were on continuous glucose monitoring along with insulin pumps. I mean, that's the beauty of these newer technology and the uses of pump and CGM. I think it should be promoted in our country in a much better way and a much structured way, because some of our patients who can really afford. We all know that Sunil and Jyoti, they have put a lot of their patients, and we have senior like
5
Dr.
minutes
Chandali
more to go for discussion.
Yes.
Yeah. So, can I come in here, Doctor? Okay, sorry. Go ahead, Jen.
Dr. Jyoti. So nice presentation. See, what we observe, and I would need your comments also. The major area where we understand that we want to replace insulin therapy, and for that we have a lot of features present in the pump which can make the insulin delivery more precise. But what the big limitation what we face in India apart from resources is how to maintain the motivation among our patients. Because I see in long term what it just becomes a quality of life issue. The monitoring disappears. Their motivation to control the glycemia disappears, and that's how many times it becomes just a convenience factor. So I think a good training and a lot of motivation segment need to be worked out for the patients on type 2 or both type 1 diabetes when we put them on insulin pump therapy.
I completely agree, Dr. Sunil. I completely agree, and we need a team. I think what I have created recently, because I had only 2 or 3 people working with insulin pumps earlier, but now I have more qualified people to follow them up, including nurses, educators, and dietitian. And it is a very hard job to keep it going. Very, very difficult job to keep it going. Troubleshooting 24/7. Even in those pump users of more than 5 or 10 years, they still repeat so many errors. I think Chandali sir will have the same experience or a better Yeah, yes, sir, please.
There's one question in the chat box, so I thought I'll ask you from Dr. Manjunath Kenny from Navi Mumbai. What are the safeguards against sudden pump runaway? We used to call, long ago we used to get that where whole insulin is injected in one, or pump withdrawal DKA. Have you seen early on when we used to use pump? These things would happen. Malfunctions were more frequent and patients were not so well trained, so DKA was there. So would you like to comment if you have gone through this, how the pumps have improved
Yes.
considerably, yet these things can happen. Would you like to describe those? Pump runaway and pump withdrawal DKA?
Yeah, sudden shutdown of the pump. Not that common in the with the new pumps, but as Antonio sir has said, it does occur. And the last month also I had a type 1 patient who didn't notice that the pump has shut down, and there was a decay, and she got admitted in a nearby hospital, and it was very bad. So insulin pump, it delivers the same insulin both as basal and bolus, and hence in contrast to glargine or Tresiba in the bloodstream, once it stops, then there is a very high chance of a decay. So we need to be very careful when we are educating the patients, and there is a news item very recently. Dr. Sulam Jain probably could have seen it, and I think we discussed in one of the forums that among the common devices used by the patients, insulin pumps can result in the maximal number of deaths, sudden deaths. And this is a report from Global. And this happens when we are probably not re-educating the patients again and again. So the patients need to be taught about how the pump malfunctions and what they need to do. But I will very briefly tell you that there are some new infusion sets coming up where the blockades will be minimal. So instead of the usual one, they'll be opening at the sides as well. So that because the commonest reason for the pump failure is it stops delivering insulin when it is blocked at the tip of the cannula. So this has been taken care of very recently. So anyway, the technology is advancing, and a lot of things have happened in the last 5 years compared to the last 50 years. So we are all hopeful.
Yeah, but Jyoti, about this pump malfunction is no insulin delivery. The biggest reason I believe is in India, our patients are not given a very firm advice on making it sure to change the cannula at 48 to 72 hours. And they keep continuing cannula for 5 days, 6 days, waiting for a new delivery alarm, no delivery alarm, which is absolutely incorrect. And if we do all these things, then these kind of episodes are extremely rare.
It is a cost factor primarily.
Yeah.
So in most of the countries, they are getting insulin pumps, CGM, everything totally free of cost. And here, it is out-of-pocket expense, and hence they try to rationalize. So they will use it for 6 days, 7 days, so the infections are common, the blocks are common. I think the type of insulin is also very important, because aspart is the safest one compared to the other two insulins in terms of pump blockade. Because Bruce Body and others have published data where they have compared all the available insulins, and glulisine results in maximal blockades and aspart the minimal. And the Fiasp, of course, it is better in insulin pumps with respect to PK/PD profile. In the insulin pump, the onset of action, offset of action is much better compared to subcutaneous. But again, when you are using it in insulin pumps, 30 to 40% of the patients doesn't tolerate a Fiasp in the insulin pump. So that is also a published data, which all of us are aware. And of those who are tolerating Fiasp, they do very, very well and much better than aspart. So these are the four insulins.
The time's up.
Time's up.
I think we are short of time now, so we'll have to stop this interesting discussion. And then may I now move on to the next session? May I? Yeah. Which is on insulin therapy in pregnancy. That's the topic. The speaker is Dr. Shailaja Kale, and the chairperson panelists are Dr. Sunil Gupta and Dr. Manoj Chawla. And introduction of our chairperson, Dr. Sunil Gupta, running his own center at Nagpur, heavily involved with RSS, DI, and DIPSI, national president, treasurer there. He has many awards to his credit, and he is associate editor of International Journal of Diabetes Developing Country. And then next chairperson, please. Dr. Manoj Chawla. He runs a center in Mumbai, Lina Diabetes Care Center in Mumbai, and he's diabetologist at the Asian Heart Institute and SL Raheja Fortis in Mahi. Founder, President of United Diabetes Forum. This is a wonderful activity. Large number of diabetologists under this umbrella and beautiful annual sessions conducted in Mumbai. And of course, he's honorary visiting faculty at DY Patil Medical Sciences Hospital. And then the speaker is Dr. Shailja Kale from Pune, diabetologist working in the field of diabetes for 25 years, very special interest in diabetes and pregnancy, and earlier associated with Dr. Yajnik's studies at the Pune's KEM hospital. She established a wonderful educational activity under Orange Diabetes Foundation and very heavily involved in CMEs, etc. So now may I invite Dr. Shailja Kale to deliver a talk. The times allotted are here for the speaker and the chairpersons.
Yes. Can I share my screen?
Yes, please.
So I think I will have some 15 minutes. I can
slideshow mode.
Full screen. Yeah, I'm trying.
Please turn off your PPT and start.
Okay, thank you so much. Sorry for the trouble. Good evening, everyone, and thank you, Dr. Professor Chandalia, for this opportunity. So, what I will like to do in the next 15 minutes is just give some background that why insulin treatment is so crucial. I don't know, my slides are not moving.
Please click on the screen.
Ah, perfect. Yes, so let's go to the main topic. So adiposity is the main problem. We know the long-term effects, but when we try to control glucose in pregnancy, what we are looking at is actually baby's adiposity, which actually we have thin fat Indian baby, and which the adiposity increases, which is already adipose children or adipose newborns in Indian population. This is from the KM long way back, many years back. It was the first publication, comparison of white Caucasian and an Indian baby who is already adipose for the birth weight. So now this small size baby gets more fat if mother's glucose is high. So baby's fat mass is mainly decided by maternal metabolic factors and insulin sensitivity prior to pregnancy and also in the late pregnancy, parity, neonatal sex, and gestational age. Maternal weight gain is again a very important aspect. Blood glucose, triglycerides, and aminocytes. So we try to control blood glucose, but we all know that it's mainly even triglycerides, which freely move with the Peterson hypothesis, we know across placenta, actually decide baby's fat.
Doctor, why have you stopped sharing? Stop the slideshow. Please put it in the slideshow mode again. I can see the PPT, but please put it in the slideshow mode. It should be in the slideshow mode.
Yeah. So Sunil and I think Rajiv is there. Who is there?
Manoj.
Manoj is there. Okay. So what actually I was planning is that in baby's fat mass is decided by maternal metabolic factors, mainly glucose and the triglycerides, which we try to control in pregnancy. So the most important point is that these thin fat Indian babies, if there is a maternal hyperglycemia. Now we know that Pat Catalano has shown that even in pre-pregnant weight or baby's adiposity, pre-pregnant obesity of the girls will also decides baby's abdominal circumference and adiposity. So we have a large of obese young girls who are getting pregnant now, and that is again increases these kind of macrosomia or adipose babies. We do not see big macrosomia, like we have a lot of publications from KM and the average weight is about 3.2 kg. So we see 98th centile of the cohort which you are studying that becomes macrosomia. So when it comes to pregnancy, we all know these postprandial peaks are directly correlating with abdominal circumference. It's not overall glycemia is extremely crucial, but the postprandial peak, it correlates with the baby's abdominal circumference and it has a very strong correlation. When we are talking about insulin treatment in pregnancy, we cannot forget, we have to discuss main conclusions or observations of the HAPO study, which is hyperglycemia adverse pregnancy outcome study. And if you see this kind of a HAPO study, which was almost more than 25,000 pregnant women, and what it showed, I will just say the conclusion, is that fasting glucose, right from it moves from 75 to 105, there is a 10 times higher chance of getting adipose baby, having a high baby's C-peptide, which is much higher, and high chances of higher birth weight. So there is a hyperinsulinemia in the baby as well as more kind of a baby's weight, which is a continuous relationship with the mother's glucose, and they studied fasting glucose, which is a continuous relationship from 75 to even 105. So though we always talk about postprandial, even the fasting glucose need to be checked and need to be monitored when we talk about pregnancy and controlling glucose. Now targets we can discuss. Sunil is here. There are different various targets, but if you see the normal pregnant girls, the normal glycemia, it moves between 85 to 90 to 100. If you see A1C, these move between 4 to 4.5. So anything above has a deleterious effect on the baby's adiposity or the abdominal circumference. So we have different targets, like fasting best is around 70 to 80, but below 90 is the target. And all postprandials below 120, which we put it as a target for controlling glucose during pregnancy. Now the slide may show the different readings, but this is for general discussion. If I'm treating my patients with insulin, just one line that proper composition of diet creates some magic along with insulin in pregnancy for that postprandial control, including fasting also. So if I'm trying to use insulin in pregnancy, insulin has to control 24 hours glycemia, fasting has to be below. So you need basal bolus. You cannot treat a pregnant girl with a twice a day insulin. We should not do it. It always needs different boluses and a basal. Even in GDM, of course, type 1, type 2, we know they need large amounts of doses of insulin. But even in GDM, those who need insulin, they need basal bolus regimen. And sometimes boluses can be 4 times, 5 times. Sometimes basal we need twice a day, according to a girl's weight and her insulin requirement. So sometimes 4 or 5 boluses, sometimes 2 basal, and then we can control. Coming back to the choice of insulin, I think
4 minutes to go.
Yeah, best studied insulin is aspart, and it has a very good studies done with human insulin. We know the insulin which gets connected to antibodies can traverse placenta. So the autoantibodies can go into the placenta. So the choice of insulin is, this is a very well done study which actually shows negligible transfer. no hypoglycemia, and baby's worth, all fetal outcomes are exactly same as human insulins. So aspart is the most well-studied insulin in the short-acting one. In the long-acting, only levemir has got studies, and because its least action on IGF-1, if we compare with the human insulin, the action on the IGF-1 is least with the levemir. So at present, levemir and the NPH, these are the best basal insulins which we can use in pregnancy. And of course, aspart and Fias, because it's an aspart, it doesn't need a different labeling. So, and of course, Lispro, but even IGF-1 activity is least with aspart. So these are the insulin which we can use in pregnancy. What I wanted to say that we all use insulin pumps in pregnant type 1 girls, many times type 2 girls. But actually I had a case which I wanted to show, a GDM whom I saw at 26 weeks. She needed more than 110 units of insulin and 5-6 different boluses. So that was one point where we use insulin pumps in some gestational diabetes patients also. Many like PCOD, IVF, and then they get pregnant. Many times their insulin requirement is very high, and there is a mixed kind of a GDM and maybe early diagnosis. So insulin pump in pregnancy creates a beautiful, wonderful, you can see the profile on CGM, which actually helps. But otherwise, 4 to 5 boluses are a must in pregnancy. The serial ultrasonography monitoring, so it's not only glucose. I use A1C when I was working with Lois Jovanik at Samsung Hospital, California. She uses A1C every week. So a serial A1C along with patients' home monitoring, where we are using our own apps and A1C, actually you can decide patients' insulin doses. Almost they need every day kind of a change in the dose. Another is sonographic monitoring of baby's size, especially abdominal circumference, and the Liker is extremely important. Hydramnios, polyhydramnios, see the Liker quantity. Sometimes head circumference or BPD may be higher, but the abdominal circumference is not. That time that slightly large baby, because of the genetics. The tall mothers or the father, the baby may be slightly big. But if the abdominal circumference and the ponderal index is not big, we can decide our insulin doses. Too much control of glucose in pregnancy, too much low glucose, you can actually see that baby's abdominal circumference is going below 25th centile, which is not good. So actually serial sonography and seeing and monitoring baby's ponderal index and which is BMI of baby, and the abdominal circumference is a must, along with glucose measurements as well as the serial A1C, so that you can have a good kind and you can take decisions about decreasing or increasing the dose. Baby going small is not good. That is because of the over control of glucose, which may happen sometimes. Sometimes, occasionally, just one this thing, that sometimes there is a polyhydramnios, baby is big and the glucoses are normal. They are not that high, which actually indicates for the insulin treatment. But occasionally we see triglycerides and we start insulin. In such cases, maybe the glucose fasting is 85 and postprandial is not high, but we do start insulin in such occasional case. So that was my take-home points, that insulin treatment in pregnancy is crucial. Even the mixed study with Janet did in New Zealand from her GDM cases, more than 40% girls were on insulin. So they need insulin. It's very rarely we can manage only on diet and metformin. Some issues about metformin, which we are not discussing today. So insulin treatment remains the cornerstone for the pregnant girls to manage their glycemia.
Time is up.
Yes.
I request the chairpersons and the speakers together to initiate discussion. We have another 8 minutes for discussion.
Congratulations, wonderful. I feel with all those minor hiccups in the early stage. Still, I feel this was, Manoj will agree with me that it was a wonderful, comments and key messages, but what exactly our delegates they need. And we should know that I feel everything has been summarized. Let us start some discussion which has not been covered. So yes. Our delegates should know that once you diagnose, see, GDM is a state of postprandial hyperglycemia. In normal situation, there are CGM studies have shown that those who are non-diabetic pregnancies, the average blood glucose is, mean blood glucose is 87. If you go to the Yojev's data, it says mean blood glucose 87. That means the fasting doesn't go even above around 75 or 78. And the average sugar is 87. Highest reading was 105. So we should try that. So if you want to achieve a the blood glucose control of a pregnant woman, of that of the non-diabetic pregnancy, then we have to be having good glycemic control. That's the first message. Now, in GDM, usually those who 70% possibly will do well on diet and exercise, but rest of the 30 to maybe 25-30% might need insulin therapy. And very rightly, Shailaja has pointed out that GDM basically is the postprandial hyperglycemia, which matters a lot. And postprandial hyperglycemia need to be covered by monitoring post-breakfast, post-lunch, as well as post-dinner. Unfortunately, many of us don't monitor post-dinner blood glucose, and you just rely on fasting and post-breakfast. Fasting will remain as 60s and 70s and 80s, and that is why we miss out many of such cases. You say that your blood glucose is controlled, HbA1c controlled, but still you have macrosomia. So this is what is very important to understand. Good quality monitoring. In rare situation, you can use CGM to see your spikes and cover it with diet. Diet, wonderfully, it can be managed, and we have tried this. A good number of papers that you can adjust the diet and do that. The postprandial peaks can also be avoided. For pre-existing type 1 or type 2, they need basal bolus therapy. Again, I feel Manoj will also agree with me that is premix insulin, very rightly pointed out, should never be used, should not use it. Though there are small data available across the country, but still we'll prefer in pre-existing type 1 or type 2 diabetes, we should use basal bolus therapy. For GDM, fasting is already normal. By using premixed insulin, you might land up with nocturnal hypoglycemia because you are giving long-acting insulin, which is not mandatory in this case. You have only postprandial spike. You may land up in trouble. And that is why monitor it properly. It has to be individualized. Insulin therapy has to be individualized by doing good blood glucose monitoring. And as the pregnancy advances from first trimester to third trimester, the blood glucose, the insulin requirement goes up. And we have to address that again with good blood glucose monitoring. Not weekly HbA1c, but my recommendation is once in a month HbA1c you can use for monitoring. I feel I have spoken too much, and maybe Manoj was pointing out something.
I just want to say one point, Sunil, which we haven't talked, is the time of the glucose checking at home. So though we say postprandials, we know the Western population has shown, Moshe Hull's studies, that 60 minutes is the peak, and Dr. Sheshaya has done studies which shows 90 minutes is the peak for Indian girls, pregnant girls. So I think they should check it at 90 minutes, between 90 and 120, not before that.
So I'm glad you answered that, Dr. Shailaja, and thanks for all the messages. My question to you is going to be the role of 1 hour postprandial in pregnancy and diabetes, and you answered that. I have a couple of...
Many obstetricians advise 1 hour, and then it becomes a lot of issues and the problems, especially with Indian diets.
Okay, so I had a couple of practical questions to you, and we spoke about what is the ideal insulin. We also know that the gray zone that glargine falls into still as category C, but getting clearances. And we're not asking about when you're initiating insulin. I think the clear choice may be preference for detamir or NPH or human or aspart. But a patient of yours who's type 1 or type 2 already on insulin basal bolus, say on glargine and aspart, who gets pregnant, are you advising that people should immediately switch over to detamir from glargine? That's question number 1. And I felt also in your conversation about the serial sonographies. Typically what is seen is, as much as we may want to do it, the obstetricians are extremely cautious about the other aspects of anxiety in the patient and family, and serial sonographies is not something that they're going to be happy with or allowing us to. I really don't know what you would advise that how you manage in those situations.
Yes, the first question about glargine, there are a good number of studies which have seen type 1 or type 2 patients who are already on glargine. So at least first trimester, if they continue glargine, there are no ill effects. And whatever outcome they have studied was not a wrong kind of one, so it is allowed. But going ahead, after the first trimester or something, because it has IGF-1 activity, it is better to switch. It is category C drug, and there are some recommendations you can use it, but I will have everyone's opinion. I don't use it after, like if someone is on glargine, I continue and very gently change it to the NPH or Detemir.
Now, let me comment on this, Manoj. This
2
is
minutes to go.
Categories of FDA has been now changed. Now they don't have A, B, C, and category. In 2015 November, they have changed it, and now they have put it on the clinician's perspective. If clinician feel that the glargine, by withdrawing glargine and switching her to other insulin, if will deteriorate the glycemic control in a person, then it can be continued. These are the recent guidelines from FDA now for pregnancy, use of pregnancy in glargine.
Yes, and about serial sonography, that question, I think as you are absolutely right, the obstetrician colleagues, it's better to call, and many of the obstetricians, though they do sonography with the sonologist, with every visit, they are actually seeing baby's size on their own, and they are very good at it. So at least asking them about the amount of liquor, but abdominal circumference you need to have, at least if someone has very high glucose or initial macrosomia, or if the liquor is more, then at least every 15 days we need to have a sonography. And you can beautifully show that it has gone down. You can see the centiles of abdominal circumference and you can show the improvement. So at least every 15 days it's okay.
Yes. I feel we have some few of the cases of using insulin pump in one of the type 1 diabetes, and also one or two of the type 2 diabetics, where the dose requirement around 135 unit in one patient, and still not getting well controlled. And we did use insulin pump. Of course, we have used it on higher basis because they're not on pump. So we have taken it on higher. So some of you difficult cases.
So that rental pattern is there. The only concern for pump in advanced pregnancies is the site where you're using it. So it would be interesting to know what site was chosen in the 8th month for insertion of the cannula.
So I have used many girls, those are on pump, and we use on the thighs. And usually type 1 it's easy because they know it. So type 1 patients managing on pump is not difficult. A new insertion of pump who haven't used any time becomes tricky in pregnancy because of the thighs and all other problems, cannulas, getting it blocked. Someone knows it, it's very easy. But for a patient who is using first time, it's, or maybe the side of the abdomen.
Times are up.
Thank you very much, Dr.
Thank you very much, faculty and speakers.
I just like to
move on to the next
yes,
talk.
I like to thank Dr. Chandalia. I like to thank Diabetes Unit KEM Hospital. Whenever I am talking about pregnancy and diabetes, I like to thank Dr. Yajnik and his team, as well as my whole team of SKDC, because we have developed lots of apps and which we are using in managing pregnant girls.
Thank you, Shah. I wish you had delivered the whole talk without slides. It would have been fine.
I did that. I was not able to see the slides.
Not really.
Yeah.
Okay. Right. We will move on to the next talk of this evening, and that is insulin therapy in the elderly. And the speaker is Dr. Rajesh Rajput, and chairperson panelists are Dr. Rajiv Chawla and Dr. Manoj Chawla. The CVs, Dr. Rajiv Chawla is running his own diabetes center, North Delhi Diabetes Center, visiting professor at the Belgaum Medical College, KLE Academy College, and DNB teacher and guide for 2 decades. Right now, most importantly, 2 assignments he's doing, which are wonderful. And this is what I did for 20 years. So I must say, International Journal. He is now the executive editor of the International Journal of Diabetes in Developing Country. And the second one, which also I did the 3rd edition. So he is very much achieving all the milestones that are possible in RSSDI. And of course, Dr. Manoj Chawla, as I had introduced already previously. So we move on. Speaker, Dr. Rajesh Rajput, Department of Endocrinology at the PGI Institute, Rohtak. You see several books, Endocrine Disorders in Pregnancy, Women Health and Diabetes, President, Indian Thyroid Society, and of been very active with the Indian Endocrine Society of India and Indian both thyroid societies. And of course, he's a reviewer with some important journal. So with that, the time allotted is on the screen, and I will request Dr. Rajesh Rajput to deliver his talk.
Thank you, Dr. Chandelia. Well, good evening, friends. Well, the topic allotted to me is insulin therapy in elderly diabetes, and I hope slides are visible and I am audible.
No, not yet. Please click
Slides
on
not visible, Rajesh.
Oh, okay.
Please click on share screen.
I have shared the screen. I will try to do it again.
No.
Unshare it and then share it again, Rajesh.
Is your PPT open?
Thank you, Professor TT. And
yeah, it is,
you
my
not
PPT
only
is
are now visible.
Okay. So the topic I am going to discuss today is insulin therapy in elderly diabetic patients. Now, why we are discussing actually? This is the most important question. What is difference between a normal adult diabetic patient and elderly? Now see, even in India, the population is aging fast. We have increase in life expectancy, and there are many myths which are surrounding when diabetes develops in elderly. Like people believe that as we age, the prevalence of diabetes is otherwise going to happen. Hyperglycemia, when it develops in elderly, is a benign condition. Now, elderly people, because of reduced life expectancy, which means the consequences of an uncontrolled diabetics are irrelevant. And good number of people believe as we ages, we keep on putting lots of visceral fat. So it is simply losing weight and probably we does not need to treat diabetes. So there are many myths surrounding when we talk of diabetes in elderly. And if we look at various guidelines, in fact, this issue has also not been addressed. But who do we consider actually as elderly? This is again a very important question. If we see, there are young old, which means 65 to 75 years of age, and old means more than 75 years of age. Now this definition is not universal. This varies from country to country. If we look in developed country, chronological age is important, and age of 65 roughly amounts to retirement age, which is actually now even coming up in our country. But in developing countries, chronological time has no importance. We consider old age begins at a point when active contribution is no longer possible. So there are some controversies around definition of elderly people, to whom we are going to define as an elderly individual. Then if we look at the association between aging and diabetes, poor diabetes control exacerbate actually the aging process. And we know with poor control of diabetes, even the life expectancy is going to be reduced by 8 to 10 years. And the quality of life is reduced by around 15 years. And poor diabetes control causes age-related diseases to develop faster. Also, poor diabetic control make a number of comorbid conditions like hypertension, dyslipidemia, coronary artery disease to come earlier. They become worse and become harder to manage. So there is a definite association between aging and diabetes. We have to treat diabetes as aggressively in elderly individual as we are doing in young population. Now, what about the diabetic data in elderly? In India, the prevalence of diabetes is around 11% in individual between 65 to 69 years of age. And 12% of the patient over 65 with type 2 diabetes have islet cell autoantibody, which means they are similar to type 1 diabetes. And WHO has projected that by 2023, more than half of the diabetics which are suffering in the world will live in Asia. And the significant number of them will be actually elderly. So what are the key challenges? If we look at the key challenges when we are discussing about management of type 2 diabetes in elderly, as we ages, our body slows down, metabolism slows down. So there is change in renal function, liver function. So there is altered pharmacokinetics, pharmacodynamics. There is cognitive changes which comes with aging otherwise, which results in different perceptions for understanding about the disease and its application when it comes to its management. Most of these patients have number of comorbid conditions. Visual impairment is a common issue. Also, whenever we talk of type 2 or type 1 diabetes, the issue of hypoglycemia comes into picture, which become more important when we are talking of management of diabetes in elderly. I have told you these patients have decline in renal function, which we will address again, and because of which the change in dosage of various drugs are required. Polypharmacy because of number of comorbid conditions, change in exercise, change in meal pattern, change in choices for the meal. So there are number of challenges, and because of the time which is allotted to me only of 18 or 19 minutes, I cannot discuss in detail about all these challenges, but these are actually important issues when we are talking of management of diabetes in elderly population. Now, as I have told you, hypoglycemia become more important. Now, this is a very important study which is published and which has shown that if we see for autonomic symptoms and neuroglycopenic symptoms and compare the elderly more than 65 years of age with middle-aged type 2 diabetic, as you see clearly in the graph, both autonomic and neuroglycopenic symptoms in response to fall in glucose are not there in elderly population. Means perception or ability to detect hypoglycemia become less as an individual ages, which means they should use therapies which causes them less chances to develop hypoglycemia, and we will come to this issue when we discuss different types of insulin. If we look back at various oral drugs, and again, this is a very busy slide and I will not discuss this slide in detail, although this slide is very important, but as I have told you, after 40 years of age, with every decade, there is a normal age-related decline in renal function. We have to change the doses of various oral drugs. In fact, the clinical efficacy for glucose-lowering effects decreases markedly as eGFR reduces with some class of agents, especially SGLT2 inhibitors. So if we are using SGLT2 inhibitors for a glucose lowering effect in an elderly, say 70 years of age, this effect is actually different as compared to 40 years of age. So there are a number of issues. Now coming to insulin therapy in elderly patients, if we see in 2017, there are 123 million people who are elderly and are having diabetes. By 2045, this is going to increase to 253 million. And as I have discussed with you, there are limited evidence of utilizing insulin therapy in elderly. This population is at high risk for cardiovascular disease and mortality. And as far as hypoglycemia is concerned, they are at more risk for hypoglycemia. And it is not only risk, the threshold for hypoglycemia, although has not been defined for elderly, needs to be different. The reason is, as we ages, we have atherosclerosis. The blood vessels capacity to change and to respond to hypoglycemia is different in elderly as compared to young population. And the consequences are detrimental in elderly population as compared to young population. They have defective counter-regulatory mechanisms and number of comorbid conditions. So probably these issues needs to be kept in mind when we are deciding about elderly diabetic patient. We should discuss about patient state of autonomy, number of comorbid conditions, and what is the long-term prognosis. And based on this, I am going to show you the next slide. Whenever we see our elderly patients, we should classify them into three categories. Healthy means who does not have any chronic disease, intact cognitive and functional status, which means they might be having a longer life expectancy. So a reasonable HbA1c goal in such population is less than 7.5%. Complex intermediate means they have multiple chronic illnesses or decline in daily life adjusted impairment by more than 2 points or mild to moderate cognitive impairment. In them, the HbA1c goal is less than 8%. Now, in those third category, which are categorized as very complex or poor health, those patients who are having number of comorbid condition, very sick. In fact, we should not target an aggressive glucose control, and in them, because of limited life expectancy, the reasonable HbA1c goal is less than 8.5%. Now, coming to insulin per se, before we discuss, this is a very brief introduction. What is an insulin secretion physiology? Insulin is secreted in basal and prandial. Basal is 50%, which is roughly 1 unit per hour. Prandial is secreted in first phase and second phase. What is happening in type 2 diabetes? Basal secretion is delayed, and the second phase is delayed and defective. As you see in this cartoon carefully, this is normal first phase and then second phase. In contrast, first phase is absent in type 2 diabetic and the second phase is delayed and defective. Also, type 2 diabetic individuals have deficient incretin secretion and resistance. So whenever we talk of insulin, we have to do physiological insulin replacement. And this article is published way back in NEJM, that all the insulin was discovered and administered many years back, and now we are having 100 years of insulin discovery. The goal of physiological insulin replacement remains elusive, and that's where the scientists are working to produce a more physiological insulin, and this becomes more important when we are talking of management of diabetes in elderly. Now, these are number of insulins available to us, and why I am showing you, because depending on the economics, we have to choose all types of insulin, but we have to understand the onset of action, the peak action, and the total duration of action. Now, this becomes important in elderly, specifically when we are discussing hypoglycemia and other issues. Now, if we look back at the limitations of current human basal insulins, conventional basal insulins like NPH, or even say for the first generation basal analogs like glargine or detamir, they have a peak effect. Variability is an important issue. Duration of action. When we want to use a basal insulin, it should have a duration of action more than 24 hours, so that ideally it can be used once a day. Fear of hypoglycemia, it should not have any peak. Why basal insulin should have a peak? Because if you are giving basal insulin at night in elderly individual, if it has a peak, there is a definite risk of nocturnal hypoglycemia. So we have a second generation of basal insulin analogs, which actually try to address all these issues. If we see the conventional short-acting human insulin analog, they have a delayed onset of action, prolonged duration of action. What does it mean? It means if you have a delayed onset of action, there is inadequate insulin in response to the meal when it is needed, which means inadequate postprandial glucose. Now, this issue becomes more important in elderly population because PPG is found to be associated with increased cardiovascular mortality. Then, because of prolonged duration of action, there is an unwanted insulin when it is not needed, which means hypoglycemic episode. Also, the human regular insulin needs to be given at least 30 to 40 minutes before meals, which means they are not fitting into the lifestyle of good number of patients. So this is where the kinetics have shown that probably the current newer generation of short-acting insulin analog, which I will not discuss in detail, which include faster-acting aspart and lispro, and the current generation of basal analogs like insulin degludec and glargine U300, they are close to physiology, they have less variability, less chances to cause hypoglycemia. Now, if we look back in the relationship between glycemic variability and the glucose level, even fasting plasma glucose is found to have a better predictability as far as the issue of variability is concerned. And the variability is found to be associated with the risk of hypoglycemia, 3-point MACE, all-cause mortality. Number of studies have shown that the newer generation of insulins have less variability, and even in elderly population more than 65 years of age, this variability is significantly less with the newer generations of insulin analog. Now, if we see aspart compared to regular human insulin, again, it has been shown that there is a significant less glycemic excursion, low risk of hypoglycemia with shorter acting analog as compared to conventional regular insulin. Last issue is safety of insulin in elderly population. There are two important studies, Origin for insulin glargine and Devote for insulin degludec. If we see insulin glargine, in Origin study, it has been shown that it is CV safe, CV neutral, non-inferiority is met, and even in Devote trial, they have shown non-inferiority for 3-point MACE. At the same time, there is a significantly low risk of developing severe or nocturnal hypoglycemia. As far as short-acting analogs are concerned, with SPART, there is a wonderful study published way back in Diabetologia, where it has been shown as compared to regular human insulin, the CV events were significantly less as compared to regular insulin, and this they have correlated with less excursions in postprandial glucose level. Lastly, when we have discussed all this, when we are managing diabetes, what is need of insulin, best efficacy with insulin therapy, safe options instead of increasing OADs where there are issues of cognition, renal and other issues. It is a wonderful therapy whenever an elderly individual, any acute medical or surgical illness, and in long term, obviously, it improves quality of life. How to start? Again, we can start number of ways, but if we look back at ADA 2021, so these are latest recommendations. They have again classified individuals into 3 classes, which I have discussed with you, given different goals depending on your functional status of elderly population, including blood pressure and goal for lipids. And even they have given an algorithm that we should use simplified insulin therapy, start with basal insulin therapy, try to avoid using mealtime insulin at bedtime so as to avoid nocturnal hypoglycemia and to prevent sudden cardiac events in the night. If we are using premix insulin, use 70% of the total dose as a basal only in the morning. If you are using basal insulin, it is preferred to give basal insulin in an elderly population in morning as compared to nocturnal administration, although conventionally we are using in night to take care of hepatic glucose output. To summarize, diabetes in elderly is linked to increased mortality, increased need to institutionalized admissions, and reduced functional status. Elderly individuals have less perception of hypoglycemia. Newer insulin analogs are safe in elderly, and ADA 2021 recommends simplifying the insulin regime in elderly adults. Thank you very much.
Thank you, Dr. Rajesh Rajput, for an excellent delivery on diabetes management in elderly and relevance of different types of insulin. You very nicely alluded to that earlier days myth that we always thought that elderly, they tend to develop diabetes as a part of growing carbohydrate, you can say, changes or physiologically. And you very rightly alluded to that we need to classify elderly in those who are actually young elderly and those who are actually elderly, where there is going to be a very lesser time. And 2021 ADA very nicely compiling the issues of elderly management, diabetes, that whether we are handling a complex type of individual where obviously targets will be more than 8 or 8.5, or someone who is going to have a long life expectancy, where we can go with intensive therapy also. And of course, we need to again highlight that not only it is the cognitive dysfunction which is much more common in elderly patient, but the way elderly patient they handle hypoglycemia in overall metabolic response, because not only they can trigger a stroke or TIA, but they are also at a greater risk for cardiovascular events moment they have hypoglycemia. So not only they are more bitter, they need to have good glycemic control, especially when you said in the beginning, which was very impressive, that even in elderly you can actually increase the lifespan by 7 to 8 years by getting a good glycemic control. Manoj, do we have any questions in the chat box, or you want to say
No,
anything?
I think currently I'm not seeing. I don't know if Dr. Chandala is seeing any questions in the
So
chat
far
box.
not received, but you can continue to discuss. You got about
So Rajesh,
4 minutes, yeah.
Sure, thank you, sir. Rajesh, thanks for that deliberation on insulin in the elderly. I was wondering why you were chosen for the elderly topic, but but
I'm young elderly.
Yeah, you are then the young elderly category, doing great justice to the topic. So, two questions, and it's something that you already showed, but I'm just re-asking you these things. One, you said that preference of basal insulin in the elderly in the morning. You want to elaborate why in the morning? And second, in the ADA 2021 recommendations also, especially in the elderly with issues and comorbidities and limited expectancy, they have been kind enough, if I can say, to change the target from 90 to 130 to 90 to 150. But do you still think 90 is fair? Practically, are we going to be looking at 90, or we'll be more comfortable with 100 up? So your thoughts?
Okay, Manoj, first, why basal insulin in the morning? See, conventionally, basal insulin has to be given in the night. But Because of the fact we have to suppress hepatic glucose output. But this holds true for those generation of basal insulin analog whose duration of action is less than 24 hours. Now we have better insulin analogs whose duration of action is more than 24 hours, in fact close to 42 hours. Now elderly individual who are at risk of hypoglycemia and where nocturnal hypoglycemia can be life-threatening. They can die suddenly in the bed as compared to a younger population. Probably based on all the risk and benefit profile, ADA even has now recommended that if we are using basal insulin in elderly and analog insulin, we have now better analog insulins. So rather than giving them in the night, give them in the morning. Also remember, always I have said at many places in the country when we are discussing and giving lectures on basal insulin, although the company people promotes that glargine or whatever basal insulin we are using, they are truly peakless. We still have to produce a truly peakless insulin. In a given patient, there is still a small peak once you have administered these basal insulins. And any peak in basal insulin, especially in elderly in the night, is detrimental. So probably understanding the benefit risk profile, AD has rightly pointed out that if we are using basal insulin in elderly and insulin analog second generation, it is better to give them in the morning to simplify as rather than giving in the night. First. Second question you have asked about is
the range, the 90
range. Yeah, actually I agree again with this range. Why? I explain you. Now the basic fundamental behind this range is it is not 150 which is important. It is a lower threshold which is more important in elderly population. Now when we have increased the lower range to 90, it means we have to change the doses to prevent hypoglycemia. I have told you, although the threshold specifically hypoglycemic thresholds are not described for elderly, but an elderly developing hypoglycemia at 80 has a different consequence as compared to a young type 2 diabetic. So it is the lower range which is more important.
No, Rajesh, sorry.
When we go less than 90, we have to reduce. You can keep 110, 120.
Sorry, I'm interrupting. The 90 has not been changed. It's 90 to 130, which has gone 90 to 150. My question was, shall it be 100 to 150?
Yeah.
So the lower one in Indian concept should not be as low as 90 in the elderly.
Okay. So again, probably we presently do not have the data because of which they might not be changing the lower value. Now, ADA, whenever changes any guidelines, they need a robust data.
I don't think there's any data for 150 either, Rajesh.
150 probably has been done with the aim that in complex type 3 type of 3 category of elderly diabetic patient, the life expectancy is very limited. So we are not going to achieve much by doing an aggressive glucose control. So even if they are maintaining up to 150, and if somebody who is suffering from a terminal illness, say pancreatic cancer, so I have seen many patients. So if we are keeping their glucose at 130, 140, 150, let them enjoy life, whatever remaining, and do not put them at the risk.
I think, Rajesh, you didn't really understood what Manoj is very rightly saying, that we are not worried about 150. Moment we talk about complex or unhealthy group, we are giving a relaxation of HbA1c 8.5. That means fasting we need to bring around somewhere around 110, then 90, because it is low fasting which will be even greater risk in terms of reducing hypoglycemia and triggering any event. So let the fasting in these groups could be even as high as 110 to 150. 150 is good, but I think 90 could be really dangerous.
Dr. Chawla, doing these calibrations of 8.5 to fasting, it is not always easy. And they have not fixed at 8.5. They have said it can be more than 8.5. So basically, you cannot calibrate 8.5 here with fasting and postprandial. Whatever they have done, again, it's a group of people who will decide. And we can keep on debating why that group has decided. That can be answered only by that group.
Rajesh will move on with sir.
One question in the chat box. So, because you see, this is similar to what you're discussing. And that is, in elderly also, where you can do CGMS and all those things. Can't you target your A1C quite low? So I'm pointing out is individualization, obviously, really you're in very good health. So really, life expectancy limited also is in general, but there are elderly 80-year-old who will live to 90, 95, the way the health is,
Sir,
See,
I tell you, although I am not that old, because Manoj has pointed out, I still remember my 20-year back story. One very VIP person to whom I have seen, and when this concept of different HbA1c or different glycemic goal for glucose has not come 20 years back, when I have visited that person and given the advice for diabetes, I have said, because I used to call him uncle, that you does not need those targets which has been given to you by your physician. He was at that time 75 years plus. So I said, ki you remain relaxed with your glucose control. Even if some readings comes higher, you have not to be very much aggressive in controlling. Hypoglycemia is more dangerous. So whether we are using CGMS, again making life more complex in elderly, 80 year of age, I personally disagree with all these things.
Manoj, we need to conclude. We have already exceeded by 2, 3, 4 minutes. Yeah.
It's your lecture, so you are.
Yeah, the time is out.
Thank you.
Dr. Chawla's lecture next.
Yes, we move on to the next talk.
Thank you, everyone.
Right, thank you very much.
Thank you all.
I request Dr. Chandelia, I request Dr. Raja, thank Dr. Chawla and both the Chawlas and Manoj. So
good thing is both the speaker and the co-chair happen to be my younger brother, but both being celebrities in their own way.
Sir, thank you very much.
Rajesh and Manoj, yeah.
Thank you for kind words. Thank you very much.
Yes. Now we go on to the last topic of today, that is insulin therapy in diabetic ketoacidosis and hyperosmolar or non-ketotic state. Speaker is Dr. Rajiv Chawla and chairpersons are Dr. Krishna Sheshadri and Dr. Manoj Chadda. To introduce our chairpersons, the speakers, Dr. Sheshadri is the American board certified internist and endocrinologist. He is practicing in Chennai. He has been a leader in setting up the Apollo Sugar Clinics, and you see, a professor of endocrinology, visiting medical education and board member Sri Balaji Vidyapeeth, President Endocrine Society Tamil Nadu, and Associate Editor Journal of Diabetes in Developing Country, Editor-in-Chief Thyroid Research and Practice, and of course very interesting. First time we see a lovely hobby. Machine learning, Chola history, and Advaitic philosophy. Wonderful. Next, our chairperson is Dr. Manoj Chadda, Mumbai-based endocrinology, DM endocrinology, PD Hospital Hinduja, Hope Care and Center, and you see, past president of the Endocrine Society of India, very active with the Endocrine Society of India, and past president of Indian Society for Bone and Mineral Research. And our speaker is Dr. Rajiv Chawla, who has been introduced earlier. And I think I would now invite, please see your timings on the screen, and I'd invite Dr. Rajiv Chawla to deliver his talk.
May I share my slides, sir? Please.
Yeah.
Can you see my slides?
Yes.
Yes, please put it in the slideshow mode and go ahead.
Good evening, everyone. Good evening, Professor Chandalia, for this opportunity to be part of this very important conference. And with two chairpersons like Dr. Manoj Chadha and Dr. Krishna Sheshadri, I'm really humbled to do this session in front of that. Task you have assigned to me is talking about insulin therapy in HONC and in DK. Well, flow of my talk will be first to discuss briefly the physiology of ketoacidosis and HONC, their clinical features, how we can differentiate, because I think it will prove prudent talking about basic condition and then going on to the insulin therapy, fluid and the electrolyte management in HONC. We know that diabetic ketoacidosis is typically a triad of ketonemia, hypoglycemia, and acidemia. Incidence tends to be as high as about 8 episodes per 1,000 patients. Well, this is in US. We don't have Indian data to say or Indian evidence to say that. I'm sure DK in our patient many times is undiagnosed, sort of type 1 is undiagnosed, so may present with DK with much higher prevalence as compared to the Caucasian population. We know that there is going to be an acidosis, persistent hypoglycemia, ketosis or ketonemia as high as 54 milligram. when we talk about pathophysiology of diabetic ketoacidosis, we know the metabolic consequences are primarily as a result of insulinopenia, which may be total in type 1, and many times it could be a partial insulin deficiency, or it could be a default in insulin therapy if patient is already known case of type 1, or it could be as a result of increase in stress leading on to counter-regulatory hormones and inducing some amount of insulin resistance by any infection, which may precipitate an episode of decay. So there is going to be a persistent hyperglycemia. Of course, it is going to be very brief because patient is immediately going to land up with ketoacidosis or ketonemia. There could be dehydration, shock. There could be metabolic acidosis, which may be very, very severe. And many of very young type 1 might go into cerebral edema while during the therapy. So diabetic ketoacidosis metabolic presentation could be because of unchecked gluconeogenesis leading on to severe hyperglycemia, osmotic diuresis inducing severe dehydration, and unchecked ketogenesis manifesting as ketosis or ketonemia, and then the dissociation of ketone bodies into hydrogen ions and anions leading on to atypical anion gap metabolic acidosis, which is seen in the setting of decay, especially in setting of type 1 manifesting as diabetic ketoacidosis. So when we try to differentiate between honk or decay, we know decay is most common in type 1. It is usually precipitated by infection. There is a ketoacidosis, I just now told you. It could have a very short prodromal symptoms. Mortality could be as high as 5 to 10% even in the best hands, and it usually present with younger age group, usually who are less than 20 years of age. Honk or HHS is of course more common in type 2, but fortunately prevalence is not very, very high. It is usually seen in those patients, those who have underlying severe disease, which may be stroke or MI, or they have already a sepsis going on, maybe elderly patient into acute pancreatitis, or those patients who are bedridden type of thing, maybe on diuretics and they are not been eating well also. There is not typical ketoacidosis. There could be longer prodromal symptoms. Mortality, well, once honk or HHS happens, it is very, very high to the tune of 40 to 60%. And these, as I said, are usually very, very elderly patient, usually more than 60 to 70 years of age. So metabolic differences between DK and honk could be that plasma glucose in DK could be definitely always more than 250, but it could be close to 500 milligram. In honk, it is typically more than 600 milligram up to 1000 milligram. We have seen the patient arterial pH, depending on whether it is mild, moderate or severe decay, it could be between 7 to 7.3, but usually in honk, it happens to be more than 7.3. Bicarb, again, depending whether it is mild, moderate or severe decay, it is usually less than 10 to 15 or 15 to 18, while in HHS or honk, it is usually more than 15 milliequivalent per liter. Ketone bodies are typically seen in decay, but it could be mild or trace even in honk also, because at times they have relative insulin deficiency, but they still have enough insulin levels not to get into typical diabetic ketoacidosis. Serum ketones are usually negative in honk, and effective serum osmolarity, which is very, very important, differentiating between DK versus honk or HHS, is it could be variable in DK, but definitely in honk, it tends to be more than 320 or 330. And anion gap typically in severe DK could be more than 12, and in HHS or honk, it is actually less than 12. And mental status in mild or moderate DK could be normal, while severe DK might have stupor or drowsiness, or also may come with coma, but HHS or honk are typically stuporous or maybe actually into coma also. Then coming on to the management and the goals of treatment, most important is the rehydration of the patient, then electrolyte deficit correction, then glycemic control, and glucose whenever needed, because many a time DK patient might also go into hyperglycemia, and how we can prevent complication in the setting of both honk as well as in DK. When talking about rehydration, we know it is very, very important to determine the hydration status right in the emergency room itself, whether patient has severe hypovolemia or patient has simply mild dehydration, or whether patient is into cardiogenic shock. If patient has severe hypovolemia, then obviously we need to immediately administer fluid, which could be in the beginning as 0.9% saline at a very fast rate of almost 1 liter per hour. That means almost 2 liter over next 2 hours. But if it is only mild dehydration, then obviously we need to just check the serum osmolarity, look for serum sodium. We may not push fluid very fast. But those patients who are manifesting with cardiogenic shock, of course, there it has to be with hemodynamic monitoring, maybe CVP line, and even with the arterial pressure checking also. Many of these patients actually will require pressure sport also with pressors. Then if serum sodium is high, then obviously we need to shift immediately. Moment you get the first report, within half an hour or 1 hour, you might have to reduce saline to 0.45% at the rate of 250 ml to 500 ml per hour, depending on the hydration status. And if serum sodium is low, then you can continue with 0.9%, again at the rate of 250 ml to 500 ml per hour, depending on the hydration status. But when glucose starts coming down, we need to be very cautious. Many people say that maybe the cutoff be 250, but guidelines usually say that let the sugar come down to 200 milligram. That is the time when we need to change it to 5% dextrose with saline at the rate of 150 ml to 250 ml. So I think the fluid replacement aims are not only to correct hydration, to correct electrolyte imbalance, and gradually wait for serum ketones or urine ketones to clear. Usually a 70 kg adult may require up to 7 liters because their deficit could be almost 10% depending on the severity of the decay. And ideally it should be replaced as crystallite rather than colloid. And usually, as I said in the beginning, we will start with 0.9% sodium chloride, and subsequently, depending on the sodium level, you might come down to half saline also. But the rate and the volume of fluid replacement, especially in HONC, needs to be modified for patients, those who are very elderly, those who have impending heart failure or their ejection fraction is low, or those who already have diabetic nephropathy, because they are the one who are likely to go into a sort of fluid overload situation also. So the fluid replacement, as I said, ideally it has to be with crystallite. There's no evidence. In fact, one of the Cochrane reviews said that there is no evidence that if you give colloid, it does better. So even crystallite would be good enough, because colloid may be very expensive and may not be available at maybe primary and secondary centers. Tertiary center, well, they do have availability of most of the colloids. Rate of fluid replacement, again, rapid fluid replacement could be practiced, but in young children, those who are presenting with decay with already altered sensorium, there again we need to be very cautious, because very rapid correction of fluid over 24 hours might put them into cerebral edema and might increase actually overall mortality with recurrent seizures also. So pediatric guidelines recommend that there has to be a cautious fluid replacement, not over 24 hours, let it be the correction being done over 48 hours time. And adult guidelines say that rapid initial fluid replacement can be done in most of the patient, those who are sort of adolescent or around 30 or 40. But as I told you, in HONC patient, again, fluid correction has to be very gradual, because you might push these patients in fluid overload situation also. And of course, starting with 0.9% sodium chloride makes sense, and depending on the sodium level, then you can cut down to half saline also. Then the correction of electrolyte is very important, especially potassium. We know that moment you start giving IV fluids, it is important to look for renal output or urine output, which has to be ideally more than 50 ml per hour. So a good estimate of renal function has to be there before we start potassium therapy. So there are, cutoffs are, if potassium is less than 3.3, hold insulin actually. Don't be in a hurry to give insulin, because then you actually may induce hypokalemia because of intracellular shift of potassium also with insulin therapy. So it will be wiser to give at least 20 to 30 milligrams of potassium per hour till potassium is more than 3.3, and then you can actually start insulin infusion. But when if potassium is already more than 5.3, then of course we don't need to give potassium immediately, but check potassium every 2 hours. It is very important, because moment you start IV fluids, and especially once you start with insulin infusion, there's going to be an intracellular shift of potassium. So even if potassium was more than 5.3, it is gradually going to come down. So maybe an assessment of potassium every 2 to 4 hours is going to be extremely important. So if serum potassium is between 3.3 and 5.3, then you may straightway start with insulin with fluid. And of course, potassium supplementation has to be between 20 to 30 milliequivalent in each liter of IV fluid to keep potassium ideally between 4 to 5. So potassium replacement, I told you, initial high potassium should not actually better early potassium replacement. Of course, every 2 hourly potassium you need to continue at the speed of 20 to 30 milliequivalent per liter until unless potassium is, as I said, more than 5.3. Potassium level should be maintained ideally between 4 to 5. Potassium should be added to fluids in concentration of 20 to 40 milliequivalent per liter depending on the baseline level of potassium. Rarely DK patient may present with severe hypokalemia, which is again not very uncommon, and in such patient we should hold insulin therapy because moment we induce severe hypokalemia, it may trigger arrhythmias and respiratory compromise also. Now talking about the bicarbonate supplementation, only to be done if pH is less than 6.9 at the rate of 100 millimole in 400 millimole liter of water with 20 milliequivalent of potassium, and it has to be infused over 2 hours. If pH is between 6.9 to 7, then it has to be half correction with 50 milliequivalent of NaHCO3 or soda bicarbonate in 200 ml of water with 10 milliequivalent, that is half potassium, which will be infused over 1 hour. But if you have pH more than 7, which is a cutoff, you should not give bicarb at all. But of course, a repeat assessment has to be done every 2 hours, and we should keep monitoring pH by doing repeated ABGs every 2 to 4 hourly till patient becomes absolutely stable. Then bicarbonate and phosphate replacements are also going to be important, but only if patient has a pH of less than 6.9. Because if you don't correct, then obviously there is going to be an impaired myocardial contractility, cerebral vasodilation, and coma and gastrointestinal complication also might worsen. If phosphate replacement is only recommended when levels fall below 1 milligram per deciliter, because otherwise it might do a lot of damage in terms of cardiac dysfunction or even respiratory depression might happen. Now coming back to the topic, which is glycemic control or insulin therapy in management of DK and HONG, and this is we also published in IJJDC last year. All of us, we have been part of this consensus, but well, there are many consensus talking about insulin therapy in management of both DK as well as HONG. But the basic is that we need to immediately start insulin, ideally as an IV route at the rate of regular insulin 0.1 unit per kg body weight as IV bolus, followed by 0.1 unit per kg per hour at a continuous insulin infusion. But all those patients who have mild DK, those who are uncomplicated, they don't have severe acidosis at all, because in acidosis giving a subcutaneous insulin may not be safe because it may get suddenly released and put patient into hypoglycemia and becomes more erratic absorption. So all those who are uncomplicated mild decay may be doing well even on subcutaneous route, where you may start with 0.3 units per kg as first dose, followed by 0.2 units per kg subsequently 1 to 2 hours. But if serum glucose is not falling by 50 to 70 milligram, this is what is a target in every first hour, then of course for another 1 hour you need to double IV or subcutaneous insulin bolus. But when serum glucose reaches 200, many clinicians feel safe that let the cutoff be 250 milligram, but guidelines say that let it be 200 milligram, immediately reduce
5 minutes to
insulin
go.
infusion to 0.05 to 1 unit per kg per hour, or give a rapid acting insulin at 0.1 unit per kg subcutaneous, and keep sugars between 150 to 200 milligram until there is a resolution of decay. But most important is that keep checking pH, keep checking electrolytes, and before you actually discontinue infusion, it is safe to give a dose of regular insulin at least 2 hours in advance, lest patient goes into again decay or severe hyperglycemia. So conventional guidelines have been saying that initiate the correction of hypovolemic shock with fluid, correct hypokalemia. When starting insulin, infuse with 0.1 unit initially. Let the fall be at least 50 to 70 milligram, and continue infusion till there is a closure of anion gap, and then you can go on subcutaneous insulin. There are advantages of long-acting analogs also, because if you are given a long-acting analog based on 6 to 8 hours doses, once patient is having stable sugar, calculate the dose based on 6 to 8 hours last dose, and you may actually start with the basal insulin, because then chances of getting a rebound hyperglycemia and ketogenesis are much lesser, especially when you are going to stop IV insulin. So even with low dose insulin therapy, there could be, there is a risk of hypoglycemia. So that is why we talk of dynamic insulin control protocols are there for DK and HSS, because there could be a greater risk of hypokalemia and hypoglycemia in those patients, especially those who are in DK, until unless you very timely stop insulin infusion, I told you, because there could be a lag between change in intravenous insulin and resulting effects. So when to initiate from IV to subcutaneous? In DK, let the cutoff be 200 or 250 milligram bicarbonate. Once it is more than 15, pH is more than 7.3, and there is a almost anion gap closer less than 12. In HHS, once you have a normal osmolarity or patient has regained mental status, that is the time you can switch to a subcutaneous regime. Glucose, of course, 5% dextrose should be always ready, because many times I told you there could be a lag between blood glucose levels, and moment you stop insulin infusion, by then sugar is already down to 100 or 120 milligrams. So you might be ready with even dextrose 5%, less patient dips into hypoglycemia. A word last slide about preventing the complication. Hypoglycemia could be as a result of inadequate insulinization, but then the risk of hypo is also very, very high in the setting of DK, especially if you have gone with a very enthusiastic insulin infusion and you have not stopped the infusion, keeping that lag in mind. Risk of hypo is also there, but then risk of cerebral edema in young children is very, very high. There you need to be very, very cautious. And in elderly patient, they might go into CHF if you are giving very rapid correction of fluid. So there also you need to be very, very cautious. So to summarize, aggressively search for an underlying precedent of DK as well as HOM. That is the way that possibly, because both these emergencies might have significant morbidity and mortality, and adequate fluid and potassium replacement should be there. Of course, with insulin, especially in DK, insulin analogs could be of benefit, especially when transiting from IV to subcutaneous. Similarly, long-acting analog, it goes right in the beginning before you switch off the infusion could be a good practice. And educating patients to avoid repeated episodes of DK are very, very vital for reducing overall mortality. Thank you very much for your patience listening. If you have any questions, I'll be more than happy to answer that. I'm stop sharing now.
Thank you, Dr. Rajiv Chawla. You have covered a lot of grounds in short time. Now, I would request chairpersons and speakers to initiate discussion.
Krishna, you want to go first?
Sure. Excellent talk, Dr. Rajiv Chawla. This is one gem that of all the changing things in diabetes, this is one thing that doesn't change over the years, isn't it? and you know, as much as guidelines are there, it is our clinical sense and common sense that actually determines
very true
the transition. I just want to sort of talk. There is this issue of overcorrecting with normal saline and pushing the patient from anion gap acidosis to hyperchloremic acidosis. And I was wondering if you could re-stress that particular issue for the audience, because it often is a very important part of the whole picture.
I think it is, you very, very rightly said, and overcorrection of anion gap in a hurry can do a lot of harm. So that is why I said I didn't go into the details, but I think an anion gap checking every 2 hours is going to be extremely important. All the electrolytes, look for chloride, bicarb, look for sodium levels, potassium levels, and keep calculating osmolarity, effective osmolarity, so that you don't do an overcorrection. In an effort to correct an anion gap, you may do a lot of harm that way. Similarly, overcorrection of fluid very, very rapidly, especially in young type 1, might induce cerebral edema, and in HOM patient also may do more harm by pushing them in congestive heart failure or fluid overload if they have incipient heart failure or diabetic nephropathy.
The second point, I mean, the two other points I want to make, and your comments and Manoj also, is one is, there was a time when we were told, this is the trip rate, this is the drop rate, and all of those. But I think in modern India, that if you don't have the equipment to handle diabetic cells, which is at the minimum a syringe pump, I don't think you should do it. I think we are advanced enough for us, if a small nursing home can easily afford a syringe pump, and clearly the drip rate, the drop rate, the nurse adjusted rate all should be avoided. maybe your comments on that, and I'll have one more comment before I add over.
I totally agree. Early days when we were doing our house jobs, our residency, that time we didn't have even insulin pumps or regular pumps. So we were doing that calculation by micro and macro drops. I worked in pediatrics where we knew that a micro set will have 4 drops for 1 ml as compared to a macro set, and we were adjusting the doses. So even in primary center these days, I think if you have a glucometer, well, in any case, managing a decay, you require ABG and electrolyte monitoring very, very frequently. It may not be wiser keeping a patient at a primary health center, but many times if it is not overt shear decay, where it is, I said, uncomplicated mild to moderate decay, many times it is possible managing even without pumps and without doing all those intensive monitoring. But ideally, yes, it has to be done so as to reduce overall mortality, to reduce the risk of cellular to reduce the risk of getting into hypokalemia, and of course going into hypoglycemia if you are giving insulin
5 minutes to go.
Very, very empirically. Yeah.
Manoj, you want to take over?
Okay, so I had 2 doubts in my mind. Rajiv, it's not to question you, please.
Yeah.
So this controversy of IV insulin bolus, number one, at the onset of therapy may be acceptable, but in between, when there is an infusion going on, why would you want to give a bolus?
I don't think it is only, all the guidelines are saying that you start with the bolus, but in between correctional bolus, depending on sugar values, you may give.
No.
But once you are on infusion, there is no reason that you should give.
I think we should get away with this boluses.
Boluses, of course.
Yeah. Only for a few minutes and actually worsen.
And then continue, and you can readjust the rates depending on the sugar done, maybe half hourly or 1 hourly.
So phosphorus is something which we read about, but we don't have available.
Normally we don't, yeah.
Fortunately, we don't need it very often.
I agree.
What is your take or experience with magnesium replacement sometimes?
Again, if it is close to 1, let it be around 2. If it is close to 1, these, especially young children, might have seizures because of hypomagnesemia. So if you have facility in a tertiary center monitoring magnesium level, I think it is worth, and a timely correction is going to be very, very important.
Yeah, especially in
Can I just add, Manoj? That,
Krishna.
So one thing is, yes, when a magnesium reaches 1, it's very serious. But remember, magnesium is an intercellular ion.
Yeah.
And therefore, the extracellular values may not
be too reflective.
So if you find a hyperkalemia that is refractory to therapy, then it is a sure sign of magnesium.
Agreed. Very true. Very true.
No. So that's the point I was trying to make is, elderly patient, diuretics, GI disturbance, a setting for magnesium deficiency.
Hypomagnesemia.
They are in a state of insulin resistance. You keep on giving insulin and IV insulin till you correct the magnesium, it doesn't break.
Right. Another thing, it is proven what Krishna very rightly said. If you are not getting a correction done by insulin infusion at a expected rate of 50 to 70 milligram, it is worthwhile looking for magnesium correction also simultaneously.
One clue is is chronic proton pump inhibitor use in the elderly. A lot of our elderly on proton pump inhibitors, and that is one of the most common causes of undetected magnesium deficiency.
Yeah, very true. Very, very practical thing. Very, very.
Do you have any questions, Dr. Chandalia? You would like?
Yeah, I think there is one from the audience.
2 minutes left.
From Mumbai. Is the incidence of insulin resistance more in the elderly? I think you might also comment on the insulin levels in type 1 going to DKA and type 2 going into HOMS. What is the difference?
I think, as I said, type 1 going into DKA are the typical one, those who are totally insopenic. And because HOM patient might have mild ketosis, but they will never go into typical decay type of situation because of 2 reasons: that they will always have enough levels of insulin. Although in elderly patient you have insulin resistance coming either as a result of sepsis or obesity or other comorbidities, but still you have enough insulin levels to prevent that ketosis being induced, what you will get typically in decay. So insulin resistance may be very, very important in setting of HOM, but you still have enough levels of insulin prevailing to prevent happening of ketonemia and ketoacidosis.
Dr. Rajiv, in this situation, especially because a lot of us take care of type 2 diabetes, maybe you also want to comment on SGLT2 inhibitors in this particular setting, because this has been maybe some more emphasis from you will help the audience.
Definitely, very relevant question and very relevant comment, especially in elderly patients, those who are already on SGLT2 therapy. We know that they are at a greater risk for having euglycemic decay, which is not typical decay, but definitely any setting of acute emergency or any setting of, say, surgery or a sepsis or myocardial infarction or a stroke, obviously these patients have to be off SGLT2. So I think that is the first thing. That actually is a risk in those patients, those who are very elderly patients, those who have incipient heart failure, they are on diuretics. If they are simultaneously on SGLT2 inhibitor, they are at a much greater risk of developing onc-like situation. There you need to be very, very cautious. So I think label still says that we should be very, very cautious. Off label, we may use SGLT2 even in elderly more than 70, but ideally you need to be very, very cautious using it more than 75 years of age.
The time is up.
Your last question, Dr. Chawla?
Thank you.
My last question, I was hoping, can you comment on pumps?
Yes,
because the common process is pump failure and people don't recognize this. What should a clinician who doesn't know too much about pump use do when a patient presents with decay?
A pump failure can push patient actually into severe diabetic ketoacidosis, because if you are not very well versed with that, if there is a blockage or local site infection, that might itself one of the reason, even if you are using pump regularly, that might be actually the reason of pushing the patient in decay. So a local site examination, and you have to be very well versed with using pump, and patient has to be taught in terms of that if sugars are unexpectedly started going up without any default on the part of the patient, we should look for a pump failure, because that may be the reason for dipping patient into decay. Thank you.
Yes.
Thanks a lot.
Thank you. Thank you, all of you. Thank you very much for the lovely session. I think this is the last concluding session. So a few remarks about our departing remarks. You see, frankly, I enjoyed planning this CME on the occasion of 100th centennial of insulin discovery. And I think a focus on insulin therapy for 6 hours was really, I thought it was worthwhile. I think next time, I think I'll take it to 9 hours so that my fellow colleagues who are such wonderful speakers and researchers, professors and clinicians do not get cramped with the time, because and discussion can be even taken further. So I think this was nice that we engage in this. I am happy that a large number participated, like in the last Saturday's session, about 3,000 people were totally connected throughout. And actually login number was very large, like 9,000, but we could monitor actual connected all the time were 3,000, which is good number. Today's data we don't have, but I expect a very good audience numbers. So I hope it has benefited my colleagues. It has removed their inhibition to initiate insulin therapy, and they have learned to undertake effective and safe insulin therapy for these patients whenever it is required, and timely insulin therapy. I think timely, safe, and effective. I think 3 mottos, if you have learned from these 6 hours of academic exercise, it will make me very happy. Thank you very much, all of you. My faculty was great, really. It was the best faculty I could get from the whole country. And I'm very happy that they all participated and cooperated so well. They're very gracious, all of them. I'm grateful to them, really, for having participated in this meeting. And of course, questions all could not be answered. It was almost difficult. Sometimes a bit hard was, so I did not know how to ask, you see. And most of them were laudatory remarks, and so I didn't have to say anything. They appreciated all the speakers very well. The audience was very appreciative. Thank you very much, all of you. I hand over to Dr. Sunil Pandey for the final closer.
Thanks a lot, sir, for this opportunity.
Yeah. So, dear faculty, thank you everyone. And audience, once again, the link will be shared to all of you to give the feedback for the mandate of CME points. and I hope everyone had an enriching mutual learning experience. So we will try to come back as fast as possible with the concluding and more series like this to be mutually beneficial. Thank you so much. Okay, yeah. Have a nice day.
Thank you.
Thank you, everyone.
Goodbye.
Thank you.
All the best.
Yeah.
Thank you. Thank you.